How are you doing today, Helen? Thank you so much for joining us.
Thank you for having me. How are you? How's the little one?
Everyone is doing well. Buster's upset that he couldn't be here today. He tried his hardest to stay awake, but alas, he fell asleep, and so did Munchkin.
It happens to the best of us. That we love sleeping. I simply understand.
I've gotten to the point where if I'm reading Munchkin a storybook, half the time I just pass out and I just fall asleep.
That makes total sense to me. Yes, makes total sense.
It's the best nap too, because it's like she just stays there reading. And, and then she reads to me and I'm just out. I'm like, all right, that's cool.
I love that. You're like, I'm not going to correct your grammar or pronunciation of anything.
No, well, it's Hungarian anyway. I don't know the grammar. I just like Lita's learning Hungarian, and I'm trying. And she asked me like grammatical rules, and I'm like, honey, I can speak it, I can read and write it, but I have had no like actual formal training. I don't know like what a gerund is in Hungarian or like how to define that. And,
you're like, I can't use a semicolon in this language. Like, I don't know what I'm doing.
I'm just mimicking. As soon as you ask me for the logic, it's gone.
Honestly, so reasonable. Also, wait, I can see, I feel like my screen doesn't usually look like this. I can see like me on one half, and then I can see kind of you on one half, but like not the whole thing.
Yes.
Does that make sense? Am I explaining what I'm seeing?
Yes, you are. So that's that new browser preview, right?
Oh, yes.
And
yes.
Because you look like squeezed to me, but I'm not squeezed on me.
Oh, okay.
Okay. Yeah, I don't know. It's weird, right?
Okay, wait. No. I think I got it. There's like a little toggle thing where you can like say, don't include my camera, which is great because I simply don't want to see myself. So this is perfect.
Oh, I just
now I can see
look at
you.
That's much nicer. That's much nicer. Heck yeah. All right. I like it.
Yeah. Wow. Okay. Hungarian though. Wow.
Oh yeah. Munchkin can point to things in any book, and if I ask what things are in English, points it out, no problem. Ask her the same thing in Hungarian, no problem.
Okay, here's the thing. I knew Munchkin was eventually going to be smarter than me, but I'm humbled that it's happened this quickly. I was kind of hoping it would wait until she was like 6 or 7, but the fact that she could probably ace the MCATs right now, humbling. Absolutely humbling.
For me too, she's already surpassed her dad. I've got nothing left to offer at this point.
And how's she and the little one getting along? Are they like having good sibling time? Is he still a little too small for them to like super connect?
So she does Bubba kiss is what she calls it. So she gives Bubba kisses.
Stop.
And then she gets Bubba cup when it's time for him to have food. And then she's tried to teach him to dance. She explained a pickle to him the other day. She was holding a real pickle, and she was like in Hungarian, she's like uborka. And then she gets Barley has a stuffed cucumber toy. I don't know why. He's got one. It's fine. And then she pulls Barley's stuffed cucumber toy and is laughing at it, and she goes this in like broken words, but still, no, eat, and she's laughing at it.
She's like, I know this looks very close to the pickle, but it is sadly not actually. Even if it was real, it would still be a pre-pickle. But like, I love that she's enjoying the humor of this pre-pickle that is not edible. That's lovely.
Yeah. And raiders, we got a raid from Blaze Winterborn. Blaze, welcome on in, you guys. Blaze is an incredible artiste extraordinaire. Make sure to check out their work. Blaze, we're doing a special charity event today, raising money for Fred Hutchinson Cancer Center. And we have back the lovely Helen Anderson, who we featured actually on our Women in STEM month back in March. And we're going to be chatting tonight breast cancer. And on Thursday, we're going to be talking about cancer and viruses.
Yeah. I think, so tonight is going to be a little more like basic, common sort of information with more of a sciencey twist, but stuff that like is good to know for the general population. And it's actually stuff that originally I designed like with the colony in mind. There's some sections that are very colony specific. And when I was practicing and like going through the information, I was like, all right, I need to know the mechanisms of this stuff because the colony is going to care about the science. And then Thursday is going to be like slightly more like cutting edge. We don't super know all of this. Like here's what's on the horizon, as well as sort of the historical context of like, why are we talking about viruses at the Cancer Care Center? So,
I feel like it's an especially important time to do this kind of fundraiser because there was a recent release on how many cancer cases cases there have been in the U.S. Last year, and with the current estimates coming through, and for 2024, it looks like it's the first time that it's topped 2 million cases.
Yeah, so we know that cancer cases are on the rise in the United States as well as globally, and we're not completely sure why. We do have, obviously, incredible scientists at Fred Hutch as well as at other institutions that are studying this. There's some arguments that perhaps it has to do with elements in the water and the environment that weren't previously there. Maybe we need to explore PFAS more, or microplastics, or other sort of things that we can see in the water that are rising in numbers. Maybe it has to do with, an increased number of teratogens just from the environment. So UV exposure, things like that. Maybe it has to do with changes in our lifestyle that are putting us at increased risk. For example, we know that, certain diets put folks at an increased risk. We know that certain body compositions can carry an increased risk. So maybe it has to do with lifestyle changes. But honestly, another thing that is worth considering is maybe diagnoses are on the rise, because our screening and technology are better. And so we're just catching more cases than we previously had. And realistically, probably a combination of stuff.
Yeah. And two, we're living longer. And I feel like that has been said in the past, right? That if you live long enough, you're probably going to get cancer eventually.
One of the things we say, I didn't even think about that, because to me, it's just that is the thing. Yes. The rule of thumb is that the biggest risk factor for most cancers is age. If you live long enough, you will get cancer. I think there's I remember chatting with one genetic counselor when I was training who said any man over the age of 90 has prostate cancer. It's just, if you get it over the age of 90, if it develops over the age of 90, it's so slow growing that it's never going to hurt you. Something else is going to come for you first, So
that's a very humbling statistic.
Now, I have seen no data on this. This was just one, cancer genetic counselor I worked with, but yeah. But it also makes it, I don't know if that makes it more scary or less scary. I'm listening to, have you ever read anything by Siddhartha Mukherjee? You or anyone else in the colony in the chat?
Sounds familiar, but I'm not sure.
He's one of my, Gregor Mendel, one of my many intellectual crushes. I'm madly in love with him in a completely platonic way. But he's written many brilliant books, The Emperor of All Maladies, The Gene, and I'm currently listening to the audiobook of his most recent, which is called The Song of the Cell, or one of his most recent. And it's just about the history of cell biology and how we've come to understand cells and the future of cellular science. And I have to admit, it's making me feel like I'm in elementary school again. Because every day as I'm walking to work, on the bus, I'm look at that leaf. That's made of cells. Look at these people, all cells. I feel like a child again, because I'm just wow, look at this, crazy.
And all the more likely something can go wrong. Puts it in perspective, right? If one of those cells goes haywire and it's not caught, you have cancer. So it's a miracle, right, that any of us are even living.
A miracle, and the power of our bodies to protect us, our immune systems and our genes.
Absolutely. Yeah. And actually, there was a study we talked about last Friday that I thought you would find really interesting in axolotl research, of all things. They use the mucus of axolotls that they release. If you massage an axolotl, it releases antimicrobial peptides, which normally bombard and kill bacteria and fungi. And they found if they synthesize these antimicrobial peptides and put them on breast cancer cells that had regular cells intermixed, the breast cancer cells were selectively targeted and killed.
Selectively?
No mechanism, but it was the breast cancer cells taken out by a axolotl antimicrobial peptide.
I was just reading a review of immunotherapy the other day for another presentation we're working on, and it mentioned something called Coley's toxins. Have you heard of this? Okay, I had not either. So apparently Dr. Coley was a scientist and a researcher and an oncologist in what year was it? Hold on, I have it somewhere. Hold on, I got the paper right here. And I wrote it down because I Googled it. Okay, 1981. And in 1981, he was a bone marrow surgeon. And he started injecting patients with streptococcal species, so with strep. And then the reason why was because then their body, he deactivated, basically a vaccine, but a vaccine against a bacterium, right? Strep is bacteria. Yeah. To get an immune response. And it was the first immunotherapy, because it was just let's wake up the immune system indiscriminately. Be leukemias. And it worked inconsistently. So he was I'm a genius. I'm amazing. And other doctors were well, it didn't work for my patients, because again, it's it's non-specific.
Right.
But
it's just like a
isn't
global
that
activator.
crazy?
That's really wild. Huh.
And again, like you're saying, it's like axolotl mucus. Like that's the thing with science that I wish more people in the general public were understanding of and like tolerant of, is that like we are doing our best and we will update you as soon as we have more information. But if the information we share next week is different than the information now, it's not because we're lying to you. It's because we learned more and our opinions have changed. Like right now, we don't know, man, but it's working. So we're going to tell you it's working. And if we find out later it doesn't work, we'll let you know. Or if we find out why, we'll let you know. We're doing our best out here.
It's better, right, to be updating as we go along versus at the end stage, right? Because I feel like if at the end stage you find out, that could have been misleading for many of people. So rather you just, here's the updates as they're coming. I feel like that's something that you, like you just said, isn't Fishman with a $50 dono, Mr. Fish, coming in hot. Guys, that's getting us closer to that $1,000 goal. 271 already.
Honestly, that's sick.
Thank you, Mr. Fishman. Guys, we're closing in on those goals.
Amazing. Amazing. It's because the colony is superior.
That's dang right. We heard that the gauntlet was thrown down, that there was already $1,000 raised collectively today, right?
Gauntlet.
We got
gauntlet thrown.
Yeah, we can't be having this, chat. We can't be having it. We're not just Twitch ambassadors now. We're Fred Hutch ambassadors. We got to lead by example.
Professionals on many counts. Yeah, which by the way, congratulations on that.
We are honored to be part of the inaugural class, so thank you all for accepting us for that.
We are honored to have you. It is so exciting. And by we, I mean Jackie, because we all know that she's the leader here and I'm just following along. I'm the little duckling. I'm just following.
Okay, well, I think we're both rabbit holing, but let's reset, Helen.
Yes.
So
we're resetting. Yeah.
What are we doing today? For those who don't yet know you for some odd reason, who are you?
Yes.
And why are we raising for Fred Hutch today? Why is that important? What is the big meaningful impact of where people's money goes to?
See, this is why you're the ambassador. Yeah. So we'll go through all three of those questions. Also, Smikes, yes, Clifford is actually in charge, but he lets Jackie think that she's in charge because he's a great diplomat. So who am I? I'm Helen. I use she, her pronouns. I work at Fred Hutch Cancer Center as a scientific content liaison. So basically, it is my job to do a lot of things, but one of them is to yap about science after learning about the science. So I do a lot of community events, a lot of community outreach. I do science writing, and I sleep very little. And I'm constantly learning, so constantly humbled. Before this, I worked in research. So I worked in a lab. I was studying a process called the epithelial to mesenchymal transition. So have you guys talked about EMT before? You guys talked about so much.
With you, we've talked about it a little bit.
So basically all that is big picture is EMT, the epithelial to mesenchymal transition, is the process by which cells go from epithelial state, so like really static, stuck in one place, heavily differentiated, living its best life, doing its very specific job, to a mobile little guy who can like move and become a new kind of cell type and like traverse the body system. And it's essential to development, right? So as an embryo gets bigger, cells gotta move, and to cancer. So how cancer spreads throughout the body. So did that for a little bit, went to the East Coast, studied genetic counseling, which is a kind of healthcare that helps people understand their own genetic information and use that information to empower them to make healthcare decisions that feel right for themselves and their families. And now I'm at Fred Hutch in the aforementioned role. Second question, what are we doing tonight? Tonight, we are going to talk about breast cancer genetics. You might be asking why. It's not October, it's not Breast Cancer Awareness Month. Part of it is that, as Balint mentioned, it is on the rise. All cancer types are on a soft increase for a variety of reasons. We're living longer, environmental factors that we're still exploring, increasing diagnosis and early detection. So like lots of things, but it just means that we should all be more aware of it. And I already kind of put together this presentation for Fem and STEM month. And I was like, seems a shame to let it go to waste. It's already colony specific. So we're talking about that tonight. And then last but not least, arguably the most important question, save the best for last, would be, who is Fred Hutch? Fred Hutch is a cancer care center, a comprehensive cancer care center, NCI designated, which basically just means that like we've been validated by really important, amazing scientists and clinicians. And we also serve as the adult oncology arm, so the healthcare providers for anyone with cancer diagnosed over the age of 18 who presents to the University of Washington for their healthcare, which is one of the largest healthcare facilities in Washington State, where we're located. Fred is also celebrating our 50th anniversary, which is pretty big. They say 50 is the new 20, so it's pretty exciting. And the reason that's big is that in 1975, when we opened our doors, we were such a small team. And now, 50 years later, Fred Hutch has over 7 different buildings. We have 2 clinic buildings specifically to patient care. We have over 240 different individual labs studying different aspects of cancer biology that are spread across 7 different research divisions, including our 6,100 faculty. Yeah, 6,100 faculty,
Wow.
Not faculty, but like 6,100 folks that are all contributing to this great vision. And honestly, just every day we're doing our best to get closer to curing cancer and infectious disease worldwide. It's the coolest hospital I've ever worked at, and I've worked at more than one, so that's actually saying something.
So how far does a dollar donation go? Like, we've talked about these examples in the past. Yeah. For example, like $5, $10, even something that someone might consider as extremely minimal. Like, how does that make an effect and impact on any kind of cancer research? Like, what does even a small amount go towards?
Yeah, I love this question. Jackie has like some specific numbers that our teams have put together for us. But the way I think about it is I'm reading this book. I'm new to philanthropy, obviously, which is where our division is housed. And that means our job is to help make sure that our research continues. The way that research continues is through funding. And historically, we've gotten most of our funding through federal grants and through government support, through foundations. And now more than ever, that can be challenging. And so more than ever, we're leaning on our communities. And I'm reading this book right now called The New Era of Philanthropy. And this is going to make sense why I'm going on this tangent, I promise. And one of the questions she posits is, how do we get people, all of us, not just, the people with millions and millions of dollars, but how do we get everyone to give philanthropically, to believe that it matters? I honestly have never been the kind of person who is able to give more than like $50 at a time to an org. My default is going to be like $10, like recently finished grad school, have basically been a student my whole life, it feels like, or working at a nonprofit research lab. And so I was like, yeah, like I someone who like resonates with that vibe, like how do we get people to care? And she was saying it's about showing people that when the house is on fire, if we can all grab a bucket of water, we can put it out, but you have to get people to actually believe that it matters. And I think that's the hard part, is that like working at Fred Hutch, and I know that Jackie's in the chat and she can also speak to this, but like we know that every dollar counts. Like we know it. But not everyone has the luxury and the privilege of working somewhere where like they get to experience that it matters. They get to experience the cumulative effect. Because like, yeah, $1 in isolation might not do that much, but if 10 people give, that's $10, and that does 10 times as much. And if 10 people give $10, that's $100, which is 10 times that. Like we're getting to very substantial sums very quickly through collective efforts,
Yeah. And that's a huge thing to be able to be part of. And then you're almost like, not only are you leading the charge on it, but you're also boots on the ground actually being able to see it, right? And so there's not that disconnect of like when you and Jackie come through and we talk about these things, that you're just like off in some other like state even, right? In like a nameless building. It's like, no, you're actually like working with the people who are doing the research and mattering on this, which is incredible.
100%. And I think that's sort of one of the other magical pieces about Fred Hutch, is that we are like this perfect size where we're big enough that we have just enough clout to like attract really brilliant scientists. And the energy is there is something like every scientist is like so curious and altruistic. They want to understand science for the sake of science, which I think is like the true scientist energy, but they also fundamentally want to help people. And so putting all of that together, you just have this really beautiful energy. And again, we're small enough still that like Jackie and I know our leadership, they don't know me, but I know them.
They should.
And like, I trust them. Like they're good people. They make decisions that I do not envy, but I believe that they believe in our mission fundamentally, wholeheartedly, and they believe in our people. And like that is a very special thing to trust your leader, trust your faculty.
It's rarer than what people might expect.
Yeah. And I've worked at smaller companies where I knew less about our leadership.
Yeah, absolutely. So that's one of the really big reasons why we partnered with Fred Hutch to begin with, is because the way Helen just pitched it is how Jackie pitched it to us to begin with. And we're just like, wow, this sounds right up in our alley of what the colony stands for. And then also when Jackie was like, yeah, we can get scientists and people who are like in the field to come talk to y'all about this too. Doing my bit. Thank you for the $5 dono. Thank you very much, doing my bit, for that support. That's why we partner with y'all. is because y'all spoke to us like in our hearts and in our words, and it made a difference. And we thank y'all for, welcoming us into your sphere and, letting us be part of this. So guys, if you even can't donate today, please consider sharing the link. We'll be doing the fundraiser during this week, and Helen will be back with us on Thursday as well. We're chatting 2 scientific topics. Tonight, like Helen said, breast cancer, which unfortunately many of us have been affected by. So tell us, Helen, where are we going with this breast cancer story tonight?
Yes. We are going to, what is the order of the presentation? We are going to start by just sort of like talking about big picture breast cancer fast facts, things that I think it can be helpful to know. Then we're going to talk about sort of cancer genetics, right? So how does cancer happen and what makes sporadic cancer different from hereditary cancer, which we've talked on a little bit before, but I think will be fun to revisit more specifically in this example. And then we'll talk a little bit about what happens when we can't control everything, right? Like there's certain things we can do to lower our risk, but there's certain things we just can't control. And there's certain things that we classify as lifestyle factors, so things that are technically within our control that aren't actually within your control in the context of cancer. For example, we know that having children at a younger age for folks who have uteruses and ovaries can lower their risk for breast cancer. Most people are not choosing to have children at a younger age because it's chemo preventive and they think it'll lower their risk of breast cancer,
Yeah.
So we'll talk a little bit about that, and then we'll talk about screening. So sort of what can folks do to increase their likelihood that if cancer develops, we catch it early, treat it more effectively. And we'll wrap up with an example question where we all get to put to work what we've explored together.
Excellent.
Love. Okay.
And then y'all feel free, as always, to ask questions, interject. The whole goal of this is for us to pull together and to learn, and for us all to come away more informed from this. So feel free to ask all questions. Blaze says, my mom has beaten breast cancer twice. The chemo gave her arthritis and fibromyalgia, but she kicked cancer's butt.
Good. I'm really, really glad to hear that. Obviously the side effects suck. And like that is something that Fred Hutch scientists are also working on. That is something, and I promise we will move on. I'll be very brief. But something that I do also appreciate about Fred Hutch is we have an entire team dedicated to what we call prevention, so the Prevention Center. But the Prevention Center doesn't just look at like preventing the development of disease. It's also really focused on holistic care. So really making sure that we're not just helping people survive their cancers, but we're holding ourselves accountable to a much higher standard. It's 2025. We've come a long way. We need to help people thrive during their treatment and after, and not just survive. I remember my mom, after her breast cancer treatment, she went to her doctor a couple years out, and she was like, I just still feel terrible all the time. And he was like, well, you went through medically induced menopause and you had half your boobs removed and you went on a bunch of different medications. You're probably not going to feel great for a long time, and you're probably never going to feel 20. And that sucks. And my mom's an engineer and she loves that kind of talk. So she was like, thank you. This was the information I needed. I feel secure now. But that sucks. We should be able to tell people that getting cancer is like having a cold and you'll be over it and you'll be fine. And I don't think that's crazy.
No, that's not the standard of what's put forth when it's going to be it's almost like this life-ending diagnosis.
Right.
Rather than being anything from that, right? If that makes sense, where it's just here, this is this information, this is what happens, and we don't know what's going on.
Yeah. And I understand that right now that's where we're at, but I don't think it's where we need to be forever. I do really, really believe that we have the drive, the desire, we have the people, we have the science to one day make it so it's not this life-changing diagnosis. We're just not there yet.
Yeah.
But
and even the holistic, as you mentioned, Helen, Jackie said that it was $150 dono even goes to helping the patients' families with groceries.
Yeah. So Fred Hutch also has housing. We have special housing options. One's the Benke Family House, for example. And these are places for patients to stay while they're getting treatment. So they can be closer to the hospital and they can, have to deal with less of the financial insecurity that can come with cancer care and the time traveling to and from your hospital and all of these things. There's so much that goes into it. We have one of our doctors who's working really hard on clinical trials to reduce the dosage so that folks are able to drive more quickly after their treatment. Because right now there's limits on how much they can drive. And he's like, for folks that don't have caretakers, this is actually a really significant hurdle in their day-to-day life. And so again, that dedication to things that I think some people think small because they think, well, it's not affecting their likelihood of living or dying. But what I love is that at Fred Hutch, that's not small. That's your quality of life. That's very much non-trivial.
Yeah, absolutely.
Yeah.
And so how does Yes, how does the breast cancer story tie in today? So like where should we begin on this?
Yeah, let's go to the next slide. Okay, and the next slide after that, because that's just our little itinerary. Okay, and so this actually, I love The Office. I'm sure many of us do. And LOL, yeah, Jackie, we're still on the first slide. I love The Office, and I love this quote where he says, "Explain to me like I'm 5." Because my rule of thumb is let's explain it at a level I think we're all going to understand. And if it's too simple, you tell me and we'll go up really fast.
Sounds
but
good.
I hate feeling dumb, so I don't want to make anyone else feel dumb. Okay, next slide. Yes. So in the chat, yourself, how common do we think breast cancer is? 1 in 8, 1 in 10, 1 in 20, 1 in 25.
I'm going to go with 8.
Good guess, good guess.
About y'all chat, what are y'all feeling?
Any other guesses? What are we thinking?
1 in 5
1 in
even.
5. You think I'm being sneaky and it's not even on the slide. 1 in 10, 1 in 8, 1 in 20. Okay. These are all good guesses. I didn't put anything on here that I thought was silly. 1 in 8. Okay. I'm wild about the person who's like, she's lying. It's not even on the slide. It's 1 in 5. Ella Rain, I think that's so good. And honestly, kind of wish I'd done that. But if we go to the next slide, you'll see that it's actually 1 in 8. So it's 12.5% roughly. And that, I mean, to some people that feels like a high number. To some people that feels like a low number. If we think about it another way, that means 7 out of 8 people will never get breast cancer. But still, 1 out of 8, those aren't odds that most of us would take casually.
Right.
You know?
It seems like it's very enriched.
Absolutely. Absolutely. Now, if we go to the next slide, we'll go through some sort of basic fast facts. So breast cancer statistics. This is just because I love statistics. And so I'm making all of you enjoy them with me. So this is sort of the main big picture thing. Most women in the United States, the most common cancer is going to be breast cancer, followed only by non-melanoma skin cancer. And that's just because non-melanoma skin cancer is pretty common because your skin is constantly being bombarded by UV light, which is one of the main things that can induce the genetic changes that cause cancer to develop. And so if you lived long enough, pretty common for one of those cancer cells to kind of develop, get wonky. And then when it's on melanoma, they excise it, they remove it, no big deal. So that's our first fact.
And because it's also because, right, we're always under the mutagens. So like UV light, sunlight can always cause mutations, and the likelihood that you're going to get it is very, very high for that reason.
Exactly. I also saw a question in the chat that is a great question. I was actually ranting to my friends about this yesterday. Is that number inclusive for all genders? So this number is very specific to folks who are assigned female. So women, as used by most of the cancer organizations and data statistics, are specific to folks that are AFAB, assigned female at birth. So folks that are born and then develop breasts, ovaries, and uteruses, naturally. But we do actually need a lot more data on folks who are trans or who undergo different sort of hormone replacement therapies because their risks are going to be different because they have different organ systems than cis folks and they have different hormone exposures than most cis folks that aren't on hormone replacement therapy for some reason. And this is also not specific to men. Men are at a risk for breast cancer, but it is a lower risk. It's about less than 1%.
And Blaze, thank you for the $5 dono coming on in. Thank you very much. Every dollar counts as we get toward 281, closing in on that 300 right there. Thank you very much.
Let's go.
And yeah, so that's, I feel like, an interesting, an important question. The way you said it too, Helen, was like, there's just so many factors that we just don't even know yet. So for anyone who's just not assigned female at birth, but are undergoing any kind of treatments, we just don't know.
Right. Yeah. And there's still ongoing research on oral contraceptives, which again are hormones that folks can take to help reduce their chance of getting pregnant. And again, there actually has been a good bit of research on that. And what they've found with OCPs, oral contraceptive pills, I mentioned this because this might be interesting to folks. I gave a talk to a sorority, and this was their favorite thing. They were like, yeah, tell us everything about the risks of birth control, because they're all women of childbearing age. But essentially what we found is that in general, birth control is safe, hormone replacements are safe, but they increase your risk for certain kinds of cancer, including breast cancer, slightly while you're taking them, but lower the risks of other kinds of cancer slightly because they're modulating your hormones in ways that increase the risk for breast, for example, but can lower the risk of uterine, for example. And this increased risk only happens when you're actually taking the pills. And as soon as you go off them, within 10 years of going off of them, if that, your levels are back to age-related risk.
Within 10 years.
Within 10 years is what the study showed, but they were it's pretty much, for most folks, it was much, I think it was much less than that. It was pretty much as soon as you're taking them. And your body's back to its baseline level of hormone levels.
So taking it while you need it shouldn't have any lifelong effects to you.
Especially because if you think about it, let's say it increases your risk tenfold. but you're taking it when you're 20. As we were talking about earlier, the greatest risk for cancer for most folks is age. And so when you're 20, your risk of developing breast cancer is very low compared to someone who's 60. And so when you're 20, even if it's a tenfold risk, 10 times a very small risk is still a small risk.
Right.
And so you might decide that the benefits of taking it far outweigh this slight increased risk, which is what many folks have, decided, and what many healthcare professionals have deemed, which is why they are still commonly prescribed.
Right. Yep. Makes sense.
On science. Crazy. Also, Sparky Pugwash, love what you're saying about wearing sunblock, because yes, Gorlins is a syndrome. It's also genetic. In some cases. And yeah, love wearing sunscreen. That's very important. Next stat, we are staying on track. Breast cancer is also the second leading cause of cancer death in American women. Lung cancer is the leading cause of cancer death. But for non-Hispanic Black women and Hispanic women, breast cancer is actually the leading cause of cancer death. We still don't totally know why. We know that Black women are at an increased risk to be diagnosed with cancer at younger ages. Again, research is ongoing into why. I wasn't able to find any super compelling scientific studies that were really, really definitive. With my, to be fair, relatively limited search, and I'm not an expert in this area, but sort of the main takeaway is just that folks that have African-American ancestry, especially if they know their family history, there's an increased risk for sort of cancers, should just request screening early, get screening early, talk to your doctors, and know what your breasts normally look and feel like. So if you notice a change, you can present to your doctor for care as soon as possible. Which is just what Pugwash said.
Yeah, personal checking to ensure that when there's something weird.
Exactly. Yeah.
It is interesting.
Do you love learning all these facts as a girl dad?
What?
Do you love learning all these facts as a girl dad? Are you so excited?
It's just oh God. Oh God. We're reaching step here.
This is what my friend said. He was like, I never cared about so many things. And now that he has a daughter, he's like, suddenly I care about things. And his wife is like, first of all, rude. Yeah, I've been here the whole time. But he's like, yeah, but I didn't feel responsible for you. You were an adult.
Yeah.
Made me laugh.
Yeah. It's also interesting too about that there's a race disparity too about presumably some flavor of genetic background too that's playing into it. But it just also goes to show how little we actually know at this stage, right? Because it's why don't we know that? Presumably it's just a genetic factor.
Because I think the thing too is even with genetics, we know that things like race and ethnicity are also not easily defined by genetics. Yeah. Right. And so it's because there's the social construct side of it. There's the biological side of melanin production. There's so much that it's how do we even parse that out? But it's why it's really important. At Fred Hutch, we have teams that are dedicated to do research in health equity. So what are the disparities? Why are the disparities? How can we reduce the disparities?
And because it's near the impossible question, right? Because it's the environmental factors that are going to be affecting you. And any epigenetic changes, as soon as that gets thrown into play, how are you going to control for that? Right? It's no idea. You can't.
Yeah. I was watching Gilmore Girls the other day. And there's an episode where one of the characters has flies in a test tube. And she's like, oh, I have to take these around and watch how many times they mate. And they're trying to use it as an example of her being annoying. But I'm just sat there this is a horrible experiment. Everyone's just taking these flies to different environments, exposing them to different scenarios. What, you're going to blink and miss something? You're just going to take it home with you? Terrible. It was Paris. Thank you, Melamoni. No, I know. I was distracted. I couldn't pay attention to the plot. My friend was like, that's not the point of this.
Hey, you know what? It's a gift and a curse right at this point. We were just able to make out a bad experiment.
So true. All right. Next up, we've got our 5-year survival. Overall, again, survival is actually pretty good for breast cancer. So like we were saying, diagnoses are on the rise, but treatments are also getting a lot better and a lot more specific. Folks in the chat have already shared, and I've shared on behalf of my mother, who has given soft consent for me to talk about it. Sorry, Mom. But the side effects still exist and aren't great. But at least survival is up. Again, we are expecting higher things from ourselves, especially at Fred Hutch, but everywhere we are holding ourselves to higher standards than that. But it is good to know that overall 5-year survival is 91.6%, and it's 99.6% if that cancer is caught early at what's called a localized stage before it can spread. And that 66% of cancers are detected at this early stage. So again, it seems like scary big numbers, 1 in 8. But then when we look at how many are getting diagnosed early and how many are getting cured, this is good.
Right. So the metrics, that 1 in 8 isn't a 1 in 8 that you're not going to make it. It's a 1 in 8 that will find something, and then your likelihoods of being able to treat it, whether, really easily or even just a little bit more invasive, but people are coming out okay at the end of it. There's still room for improvement, but it's like, it's not that initial as really scary as it sounds like.
Right, exactly. Yeah. Pigeon Coop, please correct me if I'm wrong, but isn't there a higher occurrence of like BRCA1 and 2 gene in the AJ populace? Yes. So BRCA1 and 2 we'll actually talk about later. They're an example of genes we call tumor suppressors, which help protect your body from cancer. And sometimes folks are born with changes in these genes that make them not work quite as well. And that can put these folks at an increased risk for cancer because these cancer protective genes aren't as efficient. And we do know that in folks with Ashkenazi Jewish ancestry, there's an increased risk for having these genes that don't work quite right, having these variations of the gene. For example, for a woman who has breast cancer on average, the chance that a woman with breast cancer has a variant in BRCA1 or BRCA2 that put her at an increased risk for that cancer, I think is around 2%. But if you have Ashkenazi Jewish ancestry, and you have breast cancer, the chance that they'll find a BRCA1 or 2 variant that's related to your cancer is more like 10%. So there is an increased risk for folks with different ancestries. So that's why if you go to genetic counseling, sometimes they'll ask, do you have Ashkenazi Jewish ancestry? Sometimes people are like, that's kind of a random question. But it's because we know that for some folks with certain backgrounds, there can be an increased chance.
Yep. Question from the chat. Are yearly mammograms effective? And kind of lumped in is that there was a suggestion that we'll see you in 3 years instead of yearly. So like, is there a recommendation on how often to go? Is that dependent maybe on your age or risk factors? Like, how is that determined?
Yeah, we'll also get to that a little later. But yes, for most folks starting, again, when I say, most folks with breasts, so these are specifically talking about folks who are AFAB, assigned female at birth, and develop breasts. Not sure what those risks would look like for someone who has had breasts at a later age. But for most folks that are AFAB, we recommend starting to get mammograms around age 40, and those would be annual mammograms. There are a variety of reasons someone might have more frequent screening or different kinds of screening. For example, some folks who are at a higher risk for breast cancer might start screening earlier, and they might screen, annually via a breast mammogram, and then annually, so alternating every 6 months, a breast MRI. So MRI, 6 months mammogram, 6 months MRI again, 6 months mammogram. And that can have to do with like breast makeup. So like dense breasts are harder to image. And so you want to image them more frequently, or family history or genetic risk.
And then
that's great.
Another question from Melemony is do you know if there's some kind of test coming up soon that, as Mel said, avoids the painful carbonite squish?
Yeah, I saw that, and that did make me laugh. Ella Rain, also in terms of they were like, see you in 3 years. Without knowing like your personal history, that may be perfectly normal. Your doctors are probably doing that based on your personal history and care. And I am not your doctor. So that is probably reasonable. Same with colonoscopies. They're going to tell you to get them at different frequencies depending on what they're seeing in your personal history. And then in terms of like, is there something better than the squish? Like, honestly, right now, we know that mammograms are just like a good way of imaging the breast. They are effective, but there are lots of scientists, including folks at Fred Hutch, like our brilliant, amazing Marissa Lawson, who are studying different techniques and the efficiency and efficacy of these techniques to see, like, are they comparable? Is there something that will perform as well, as reliably, and as accessibly as mammograms without the squish? Because, like, no one's excited about that. And actually, some women list, like, the pain and discomfort as reasons why they don't get their mammograms. And so if we can reduce that barrier,
and then the preventative, right, doesn't then work because you're not going because of the pain that's associated with it.
Exactly. Yeah. No, for sure. Squish is hard. They do be needing it for the image. But one day, in the same way that I'm optimistic, one day cancer will be like a cold and you'll be like, oh, I'm inconvenienced but not devastated. My hope is that mammograms will one day be like dental cleanings, where you're not like hyped, but you're not like, oh no, it's going to hurt. Actually, I'm kind of a baby. I kind of hate going to the dentist.
I was going to say, I really hate going to the dentist.
My dentist is perfectly nice.
Yeah, no, it's irrational of fear, but it's still just something like playing around in your mouth.
Honestly, it's a good thing I'm kind of scared because I don't know about you, but my dental hygiene is impeccable. I floss so much because I'm scared of the dentist. I'm like, I need to spend as little time as possible in this office. Like, he's so nice, though.
Yeah. I just don't trust him. Like, why are you spraying in my mouth, man?
Yeah. And then they're trying to talk to you. Their hands are all over your face. And then they're always giving me crazy recommendations. I remember we'll get back to science. The most unhinged thing the hygienist said to me recently. She said, did you know there's a little coffee staining on the back of your teeth? Sorry, the back? Simply who's looking at the back except you? She was like, you could try drinking your coffee with a straw. I was like, my hot coffee with a straw? No.
I mean, if you direct it like down your esophagus anyway, right, then that'll bypass you burning your tongue.
This is what she's basically recommending. She's like, do you want to take that thing that gives you comfort every morning and just get rid of it? Like, what? Here's the thing. I'm being sassy with you now, but in the moment I went, that's a great idea. Thank you. Because I'm terrified of the dentist. I can't be acting out there.
No, I mean, yeah, they got the blades right around you. Be like, oh, so you're going to try that straw, right? Yes.
Also, like, again, because I'm a crazy person, like, she's a healthcare provider. I don't want to be medically negligent. I don't want to, like, dismiss her insight as the trained professional. Like,
yeah, I told them, like, all right, I'll switch to tea. And they're like, yeah, that's not going to work either for us. I'm like, oh.
That's so funny. You're like, work with me here. I'm trying.
I really want to. But like, no. We're gonna need to do that differently. Yeah, we need something totally different.
Okay. Average age of diagnosis is 62 years old. Again, age is the greatest risk factor for most folks. But we know that diagnoses in women under 50 are increasing by about 1% per year. So again, that's not like a super dramatic risk, but it's a non-trivial increase. So it's something that we're monitoring as a society and trying to explore why. And I was going to say more importantly, arguably more importantly, depending on who you ask, not just why, but what we can do about that.
Yeah, because it seems like that would be a great place to continue like early screening. But if it's also like we were talking about earlier, if it's going up for different reasons, and not just because of increased screening, then it's like, how do you counter those things as well? So it's
exactly.
Yeah. And then are these numbers for US or is it worldwide?
These numbers are for the US. My data, I included a source at the end, but I mostly am using CDC data, the SEER data here. And I'm also looking at other trusted sites like FORCE, Facing Our Risk of Cancer Empowered. And who else did I go to? Oh, just like the NIH, like a couple different like NIH resources and like peer-reviewed journals.
Gotcha.
But most taking place in the United States. Yeah.
Nice.
Sparky, you bit your dentist? I'm sure they were.
No, yeah. I mean, Sparky, as you should, right?
Okay. And then our last fun fact. Oh, yes. Our last fun fact is that early breast cancer often has no symptoms. So that's why getting your annual mammogram or screenings at whatever timeline and whatever methods are recommended to you. And knowing your family history, so you can be best informed about when you should begin your screenings and how you should begin your screenings, are really important because that way we can catch things before there are symptoms. And again, it's good to know what your breasts look and feel like because that way, if something does change, you're aware of it. It's actually something called clinical breast awareness. And remember when we were learning about it in grad school, my friends and I were like, no, you have boobs? And my instructor was like, no, you guys, like, know what they're like. Not just know you have them. And we're like, we're idiots. I'm so sorry.
And Pidge, thank you for the $10 dono, getting us to $291. Y'all were almost at $300 on our day one of 2 of the fundraising with the $1,000 goal.
We're almost a third of the way there. That's actually incredible.
Yeah.
Like, that's super exciting. I love that.
Remember, y'all, if we get to 500, we'll do a t-shirt raffle, 1K for another t-shirt raffle, and then we'll put everyone in the hopper who donated 25 or more for a Fred Hutch pin that we'll raffle off on Thursday. You don't have to be here for that one because we'll just take the list of names, put you in the hopper, and do the raffle. So, guys, thank y'all for your generosity and your donations today.
Love. Okay, so now we have a fun game because I love doing games with the colony. So what increases my risk for breast cancer? So again, some risk factors can be modified and others are out of our control. So, yes, some examples. So next up,
I like the images. I like the well done.
You gotta. I stole them from your website. You should like them. They're beautiful. Also, Antonia is such a pretty name. I'm like actually kind of obsessed with it.
Well, but you know why we picked it, right?
Because of Ant?
Yeah. I'm sorry. There's no other significance beyond the pun.
Like, she feels like an Antonia.
No, it's just the pun. It's just the pun.
Well, I love it. I think it's great. I'm into it. Yes, but okay. Answer in the chat. We've already got some answers we love. Who's at higher risk? People that are assigned female at birth, folks that are assigned male at birth. Again, we're starting small. I see an AFAB. I see an ant side. Yep, Antonia. Assigned female
again. Yep.
Love. Yeah, we can just go to this one because y'all know what it is. Yep, it's folks who are assigned female at birth. Although men can get breast cancer, it is much more common in women. So less than 1% of men and about 12.3% of women, or about 1 in 8. And the reason why, kind of two biggies, there are many reasons, but two of the biggies is that most breast cancers are driven by estrogen. And that makes sense, right? Because we know that breast development is driven by estrogen. So it makes sense that your breast cancer cells, when they're sort of getting kind of freaky and they're growing and dividing like they're not supposed to, they're like, I need to grow and divide faster. I need to be more sensitive to this thing that already helps me grow and divide. So they increase their expression of what we call estrogen receptors, or ER receptors. And that helps them be more sensitive to estrogen, and then allows estrogen to further drive their growth.
And
Men
so,
don't make as much estrogen as women. Oh,
right.
Yes.
And then that growth that could also be contributing right to the cancer itself, right? Because you're promoting cell growth.
Right. Exactly. Yep. So the estrogen is speeding the breast cancer to grow. And then as you're increasing the number of cells, then they're all dividing. So it's this multiplicative effect. Yeah.
And it is interesting, I think, and important that we point out that men can also get breast cancer, because I know when I was a kid, that wasn't really a thing that was talked about.
Yeah.
And I think there was like a Scrubs episode or something where there was a male patient with breast cancer. And that was, I think, the first example in pop culture where it had actually like transcended that men can also get it. Like the risk factors sure are very different between the two, but it's just that, you know, like the chat was saying, like testing and paying attention to your body isn't just for women, but it's for men too on this as well.
And also like knowing your family history. Like, for example, if you have a family history of male breast cancer and you're a male, or if you have Ashkenaz Jewish ancestry, or you have a certain genetic variant, like if there are reasons that you suspect you might have an increased chance of developing breast cancer, whether you're male or female, you should talk to your doctor about that. Because just because men have less estrogen and less breast tissue doesn't mean it's impossible. So like, you should still be thoughtful.
Right.
What we say is that unless you don't have the organ, there's a chance it can get cancer.
Right. Because like we were saying at the beginning, at a certain age, you will get cancer. And if it cells, that's what the target is. So if you, guess what? If you have cells in your breast, whether if you're a man or not, that could be a target for there being cancer. And that's how prevalent it is in everyone. And that's why this is so important to study, and how that's why it's also terrifying. And that's why it's important that we demystify this, right? Because it can just be something where you hear that C word and immediately everyone's like, oh God.
And I think also what you were saying too about like how it was like on a Scrubs episode, I haven't seen that, that episode of that show, but I imagine it was kind of almost treated with a little bit of a comedic effect.
Oh yeah.
Because a lot of times male breast cancer is like a funny thing. We're like, haha, he's like not a real man. He has breast cancer or whatever. And it's like, that's crazy. Cancer isn't this thing that is like gendered or says anything about your morality. But for so long, our society did view physical disfigurement or physical disability as a moral failing. And so that still pervades to this day. And that can be really challenging for folks with all kinds of things, including, like you were saying, cancer, the C word. So many people don't even want to talk about it because they're embarrassed or ashamed, or they're just scared. And talking about things that are scary is hard.
Mm-hmm. Yeah.
Absolutely. I was talking with kids, and it's interesting because they were like, what's the hardest part of your job? And obviously different jobs, the answer is different. But what I said for science communication was that sometimes there are things that are really big and scary. And I was like, again, they're kids. So I was like, do you guys like talking about things that scare you? And they were like, no. And I was like, neither do adults. No one likes things that are scary. And that's why sometimes science is hard to talk about, because people don't realize they're scared. And so their feelings come out as anger.
Yep.
And that makes it really hard to be constructive and collaborative with one another.
Right. Or if you're trying to, like in the situation, the men's breast cancer back in Scrubs, where it's that comedic effect, it's just that you don't know how to talk about it. So you're trying to, package it in a way where it's accessible to some, but then off-putting to those who are maybe affected by it.
Right. Because I imagine that would be so hard as a man to go to your doctor and be like, I think I have breast cancer. Like women, we're conditioned more to be comfortable saying like, oh, I think this could be breast cancer. It's still scary, still weird, you're still insecure. But like, we've been taught that like that is a thing for the most part that would be okay for us to have.
Right.
But men aren't conditioned the same way, which is actually really hard.
Yep. And so societal influences affect the likelihood of us actually, going to the pre-screenings, which is the whole, like a lot of these, like even medications, people buy in. People don't buy in, it's not going to work. And so that's a big thing that we have to combat as well. A question from the chat is, would a total hysterectomy help reduce a risk?
Yeah, it's like hysterectomy, like removal of the uterus. So that would reduce your risk for uterine cancer. But we actually know that estrogen is made by other gonads. So it's not your uterus doesn't actually necessarily make the estrogen levels. So you wouldn't be menstruating, your body still have hormones. We know that a prophylactic double mastectomy, so prophylactic meaning before cancer develops, before you have cancer or any known, detectable cancer, a total, what's the word? Now I'm forgetting it. Oh, mastectomy. So removal of the breasts in a surgical way designed to remove the breast tissue can significantly reduce the risk of breast cancer for women or folks that are at risk for breast cancer, regardless of their gender or the sex they were assigned at birth.
So there's been a couple of big examples of that too, right? Like people who are in the public sphere, or like in seen by a lot of people, where they have like
famous celebrities.
Yeah, they have like the BRCA 1 mutation or 2 mutation, right? So it's a higher likelihood, and then they don't have cancer yet, but there's just the possibility, and so they get the double mastectomy. Yep, Angelina Jolie, I think it was. Yeah.
Yes, it was. Yeah, because I remember that was like one of the first times people were talking about BRCA 1, because she was like, I have this risk, I'm going to have this surgery to reduce my risk significantly. And that's because some people, like you were saying earlier, the prevention only works if you're doing the screening regularly. And even then, we're just hoping we catch it early. There are things we can do to reduce our risk. There are certain medications folks can take to lower their risk. There's certain lifestyle changes folks might be able to make. But even then, some people are like, even if I'm lowering my risk, even if I'm going to catch it early, I just don't want to get it at all. And so we do know that, again, removing as much of the organ as possible is in some ways the most effective way to reduce the risk of developing cancer in that organ.
So that's the catch, right? In that organ.
Yeah.
Right. Next fun fact.
One. Yeah. Okay. Who's at high risk for breast cancer? Someone who drinks 3 glasses of wine per day and someone who does not drink. Now, these days, y'all might know it, but this is actually relatively new in terms of like our historical understanding of cancer.
Because I feel like it would just go against the grain, I'd have to say the one that doesn't drink.
Love going against the grain. Yeah.
There is a reason for it, because there's that resveratrol molecule in red wine that has been shown to be preventative against aging, not necessarily in human models, but in others. So maybe that has to help prevent like free radicals and maybe DNA damage.
Do they think it has to do with, I remember like skimming that article a million years ago. Do they remember it has to do with like anti-inflammatory processes, or what was it again? Did they figure out what the mechanism was in the mouse model?
I can't remember if they had figured it out or not. I know they tried it in fruit flies, and they did also find that free radicals were more likely to be caught up by the resveratrol and some of the other the molecules they had put, so they did extend lifespan. And they just used like the GNC like powdered pill, like they opened up the capsule and poured it out, mixed it in their food, and the flies live longer. So I don't know, but three glasses of wine per day is also, it's a little bit boozy there.
First of all, what a life! I simply can't imagine the lifestyle that would allow that kind of behavior. But send it, I guess. But actually, someone's guessing. Okay, I'm seeing a couple guesses for does not drink at higher risk. Sparky Progress does not drink because they're more stressed. Pigeon Coop also explained because that thing wasn't to with tannins. Okay. Wow. So I'm seeing in the chat only one person who's right, and they're right by a lot of data. It is the person who drinks 3 glasses of wine per day. And if you go to the next slide, you'll actually see what we know. It's actually women who have 1 alcoholic drink per day increase their risk by about 7 to 10%.
Wow.
And if you increase by 2 to 3 drinks, it increases your risk by up to 20% higher. And the alcohol is linked to other kinds of cancers, including colon cancers and other types of cancers like pancreatic. And there are a couple different theories why. So there are a few different scientists at Fred Hutch that are studying this. Holly Harris did a big study. She's in our public health division, and they were doing a study on sort of like what diets can influence our risk for cancer, including breast cancer. And what they found was that different diets put you at slightly different risks, but the only statistical difference was when you have alcohol. So like alcohol is the thing that really makes the big difference. And then there was another study that was validating this. Let me see, who was this? I want to pull this up. I actually linked it because I thought it was really cool. Yeah, so this study was also just showing that alcohol is linked to certain kinds of breast cancers and a significant increase in risk in those kinds of cancers.
And Melemony, thank you for the $12.34, putting us to $303. Guys, we crossed $200 already. Thank you so much, Melemony.
Love. Amazing. Thank you. But not necessarily non-hormonally driven kinds of cancer. And that's because of the mechanism. So this is what I was deep diving on. And we still don't So as you're talking about your axolotl, it all comes back to your axolotl mucus.
Perfect.
Sometimes we have data and we're like, y'all, we're still figuring out the why, but we absolutely, confidently, definitively know the what. And the definitive what is that drinking alcohol more than 1 glass per day can significantly increase your breast cancer risk for folks that have breast tissue, for folks that are AFAB, for folks that are women. And still have, all the parts. And we know that it's been well documented, and we're theorizing why. So the study that happened at Fred Hutch showed that you're at increased risk for certain kinds of breast cancer, but not others. And the difference between the kinds you're at risk for and not at risk for are the kinds that are hormonally driven. And that's because we know that alcohol can affect your body's level of estrogen. And as we talked about earlier, estrogen is one of the main drivers of most kinds of breast cancer. And then, because I'm like the colony and like you, I was like, but why though? But how? And I found a couple different theories online that seemed like mostly legit papers, and then one that does not seem legit. So I'll share it, but I don't think it's a real source. So the ones that seem legit, the first one is that it impairs your liver metabolism. So you know that our liver is like the filter for our blood, and it's the filter of like everything in our bodies. We often talk about it as being the filter for alcohol, but it filters everything, including your hormones. And so if you're taxing your liver with alcohol and your liver is distracted, it's focused on breaking down that alcohol, and it's not as good as breaking down estrogen. The estrogen levels can build up, and they can increase your risk for breast cancer. And over time, alcohol can damage the liver, which can then just lead to generally worse function at
So even
estrogen.
if you then stop drinking, you're at a handicap with your liver, so you're going to let more of those hormones through, thereby increasing the likelihood you're going to have something happen with cancer.
It's a little bit like, honestly, it's a little bit like smoking and lung cancer, a little less dramatic, but like if you smoked a cigarette once when you were 18 because a cute boy was near you and he thought it was cool, like you're probably fine. If you went binge drinking one time when you were like 20 and you like absolutely destroyed yourself for a single night, you're probably okay. But if you're drinking an entire bottle of wine every night, that's probably going to put you at an increased risk in the same way that smoking a pack of cigarettes a day would put you at an increased risk. It's also important when we talk about things like alcohol and like different kinds of substance use to again kind of come back to what we were talking about earlier. There's no moral attachment to this. Many people choose to drink or not drink for many different reasons, and it doesn't say anything about who you are as a person. We just have these facts that I think people should be aware of so that they can use this information to inform their decisions. But like, it doesn't, you still make the decisions in your life, you know?
Yep. And Ella, thank you for the $11.66 dono, getting us to 315, back to a whole number. I imagine that may have been intentional. Thank you very much, Ella Rain.
Love a whole number, woman after my own heart. Love.
And Coffee Rocks is wondering where does estrogen primarily produced then? Is it specific to the ovaries? Is it then also located elsewhere in the body? I guess also because then it would be coming into where a man might also have elevated estrogen levels too. Believe there's other organs that would also produce it, right? I'm
pretty sure it's ovaries and your adrenal glands, which are like on your kidneys. And they make, but watch me Googling it right now. All right, let's see. All right, so that's my guess. What are they saying? What's the internet saying? Because that's a great question. I don't want to just assume. All right, let's see. Okay, yep, there's the three forms. I knew this: estrone, estradiol, estriol. Yes, correct. Okay, but where does it come from? Okay, your ovaries make most of your okay. All right, this is Cleveland Clinic, legit source. Ovaries make most of your estrogen during your reproductive years. Yes. Adrenal glands. Yes. And adipose tissue, body fat, secrete estrogen too. We knew that, and we know that because we know that increased adiposity, so women who have higher body fat content, can be at a slightly increased risk for breast cancer because we know that adipose or fat tissue can make estrogen. So we know that that's a thing. And also the placenta secretes estrogen during pregnancy. This makes sense. But also during pregnancy, your body is regulating its hormones. So pregnancy is not necessarily, I don't have to add the necessarily, it's not considered a risk for breast cancer.
Gotcha.
Yeah. So there's a live Google with the colony. Yeah. Okay. So one is that maybe it's because your liver is worse at processing estrogen, so estrogen levels build up. The other one that also comes from like a source that seemed legit when I was rabbit holing is that alcohol can influence the activity of enzymes called aromatases. Do you know about aromatases?
Mm-mm. I imagine it's flavor related, smell related, aroma?
I wish, but no. Devastatingly. They're involved in the conversion of androgens, so hormones like testosterone, to estrogen. And so we know that alcohol can make aromatases more effective, so they can increase that conversion to estrogen, again, increasing level of estrogen in the body. things that increase estrogen tend to increase your risk for breast cancer, certain kinds of breast cancer, the hormonally driven kinds. And the third reason I saw that seems kind of fake, but like is maybe real, but I couldn't verify, is they were arguing that some kinds of plants have a kind of like molecule that they were calling like phytoestrogen or phyloestrogen or something that the human body can interpret as estrogen because they look chemically similar and it can be found in some alcohols. But I don't know if that's real or not.
So if that were to be real, and again, we're just kind of spitballing with ideas here, would synthetics that are like located in plastics that are also estrogen mimics, could that also be then, if we assume one is correct, that could also be then leading to this like external factor that could be influencing it too, right?
Yeah, I think the idea that if there's something that your body interprets as estrogen and it treats it as estrogen and it acts in your body like estrogen, then perhaps it could put you at an increased risk the way other kinds of estrogen can.
Right. So even if it's a synthetic and it's not actually estrogen, but just a mimic or whatever molecule, it could be causing an off-target effect like that, which would be...
Yeah, is the theory of this very untrustworthy source I found. Yeah.
It's an interesting theory for sure. We'd have, I want to dig and see like what the other papers are, but I think that could be, I think that's the argument for like the synthetics like that are in plastic that have caused and been associated with cancers. I don't know about what it would be for alcohol, but that's just an interesting idea to it too.
Yeah. I hadn't heard that about the plastics. That's interesting that it mimics something else in our body that's like a driver in some way, or might like in some way influence like the expression of oncogenes or something. Yeah, that's interesting. If it looks like a transcription factor that could induce the expression of genes differently. Yeah.
It's a tough one. And a question from chat too is about like for hormone replacement therapies and how that might influence it. We did talk about at the beginning how we don't really have data on people at least who are transitioning, right? So a lot of the metrics that we're talking about today, it's not that we don't want to talk about metrics in other people, it's just that we don't have them. And like with funding being cut nowadays, the likelihood of getting that basic data is even harder. So, to help, like that's another reason why we have to do fundraising on Twitch and other locations and not just depend on the government, is because those programs are being cut. And so you can't help as many people and you can't have that big of a population anymore.
Yeah. One of the questions that someone asked that at a fundraising event recently was like someone who works in the pancreatic space was like, how does prostate cancer raise so much money every year? Like we're really struggling in the pancreatic cancer space, like get enough funds to do our work and take care of our patients and do our research. And, one of the prostate cancer experts was like, well, we work really hard as a team and we collaborate and we do well. And that is accurate. And one of the other, doctors there was like, and also prostate cancer is often curable. It's very common. And many of the patients that we have then get diagnosed, they get treated, and they live a long time. And they're often older men who often have the means of philanthropic giving. So they were
God, I hate it.
They were so much. Common, so there's lots of them. It's treatable, so there's lots of survivors, and they are rich men, powerful, and it's good. Like we want people to give philanthropically. That's amazing. Like that's incredibly generous. But this doctor was like, it's also our people, they're around and capable of giving, which is wonderful. Diseases that are more rare, smaller sample size, and diseases that are more life-limiting, again, smaller sample size of survivors, and diseases that affect different populations may be less able. They may just be focused on trying to survive and then forget about it, So just different theories.
Yeah, I think it's really, really well put, as just like all the different things that could be influencing whether or not you're going to get financial support and you're going to have people to be able to help, which is why these are so important to do. And like you said, even the small amounts add up.
Yes. We have a whole group. We have different communities at Fred Hutch that support us. And there's one called the Innovators Network. And it's specifically donors that are under the age of 45. So really folks are like early career and they're like, we know you are early in your giving journey, but if you want to feel community with something, if you want to support something, like this is the group of people for you. And it's a lot of people who give $5. It's a lot of people who give whatever they can, which is usually not individually a big sum. But since the Innovator Network's inception in the early 2000s, I want to say, we just this year hit our $20 million goal, which is crazy. Because again, that's the power of like community work.
Yeah, absolutely. I am really this is a really cool bit of data. It's a really cool bit of data. I liked being wrong about this.
Yeah. And again, as you were saying earlier, like there are no right or wrong choices. Well, I mean, there are, but like when it comes to like certain lifestyle choices that aren't hurting other people and that are only impacting you, there's no right or wrong. But I do still believe that like science not shared is science not learned. So I think that everyone should have access to the data. And this is what the data tells us.
Yeah.
So,
which is something that isn't accessible. Like we were talking about this the other day of like, how does one go from like a news source or a Facebook post to the actual data and then be able to interpret it? Like that, there are like two giant skill sets right there that are not taught.
Yes. And there was like, and that's like with the crazy article that was like, maybe it's the estrogen mimics in plants. I was like, where is your data? Where is this from? And the source was like, I don't know. And I was like, where then? Like it came from somewhere. You're saying a lab. Give me a link. Give me a name. Let me dig.
Yeah.
But like they wouldn't let me dig. There was nothing to dig. I know.
And that's just because you knew how to dig too, right?
Yes.
And not everyone is blessed enough to know that skill. That's why it's so important to do what you do, to do what we do, is because it kind of demystifies that thought process.
Yes. Yeah, absolutely. Absolutely. 100%.
Okay.
Yeah.
Another scenario we've got here.
Yeah. I'm curious again. So we've talked about how like hormones influence breast cancer. So I'm curious what people think. Who's at higher risk for breast cancer? Someone who had their period at 14. So their first period, also sometimes called menarche, or someone who had their first period at 11.
I'm going to go with 17.
17. Okay. Tell me why.
I don't know. It's just a feeling that there's like the fact that the hormones didn't kick in when they were normally supposed to means there might be something with like the pituitary gland that's off. And so that could be that hormonal misregulation of the delayed first period is what's leading to that kind of effect. But I may very well be totally wrong.
No, that's good. That's good logic. Good logic. In the chat, we're seeing some 11s. We're seeing some 14s. Again, I love these people. I think I'm cool enough to pick something that's not on the slide. I aspire to it. Next time, I'm going to do that. Next time, I'm going to pick something that's not on the slide. So you've been warned. 17. Okay. If you go to the answer, maybe it's a secret.
We go backward. Oh, hold on. No, it's not going forward.
Going backwards is good too, you know.
There. At 11.
Yes. And it's just because women who've had more menstrual cycles, because they started menstruating early, typically before the age of 12 is when we consider that an increased risk. They have a higher risk of breast cancer, and it's because their body's been exposed to estrogen longer. So the person who had their first period at 17, typically you get your period typically, I think, about a year after initiation of puberty. So the initiation of like breast development and other changes. And that's typically around the time that estrogen levels start to rise, as well as other hormone levels. And so the idea is that the person at 17 has had a delay by about 6 years on the other person of the rise in estrogen.
So you have a buffer.
Exactly.
So could then one explanation for the increased incidence of breast cancer is that there are earlier periods?
I thought about this too. And one of the theories behind that had to do with like perhaps children these days have higher adipose levels, so have higher body fat content, which could be increasing estrogen. Again, and the other thing that I also talk about a lot is when I was doing presentations anytime I'm doing presentations for any audience, but especially for young female audiences, young femme identifying audiences, the rate of disordered eating in this country is criminal for all genders, but especially for young femme presenting folks. And so I'm always so sensitive and thoughtful and gentle about the way we talk about this, because you can, first of all, body type, you can only control so much. And so just telling women like obesity puts you at an increased risk for cancer, again, I don't think that's a helpful way of wording it. And I don't think it's accurate. We know that adiposity, higher levels of adipose tissue can put you at an increased risk. That doesn't necessarily have to do with what your body looks like or the size of your body. And I think especially for young women, like when you are 10, you are not in control of what you are eating necessarily. You are not necessarily in control of what is happening in your life. And so I also think it feels strange to put any sort of pressure on a person that young. So those are my caveats. But yes, and I was also doing some digging to see if any of those things are related, and I couldn't find any sort of peer-reviewed paper that confidently made those links for me.
It might be young enough in terms of the theory that it just hasn't like had enough time to be studied out. But yeah, like you said, how estrogen can be released by adipose tissue, presumably at any life stage that could be influencing it. And yeah, and it's really, really difficult that if if it's your diet that's involving it, when you're 10, you're not deciding if you're eating, I don't know, pizza or snap peas. I just pulled those examples right out of my head, but like that's not how that works, right?
The two food categories, pizza, snappies. But also like everyone's metabolism is different and everyone's bodies look different. And just because your body looks a certain way doesn't necessarily tell us anything about your adipose content. And it doesn't tell us anything about your health. And it doesn't tell you anything about your hormone levels. Like there's a lot of disparate things that together are linked. And again, like you're saying too, there are probably different ages that it's more or less important, right? So it's probably more important potentially when you're at the age where you're at a greater risk for breast cancer, but maybe not, like there's so much to parse out. And again, I feel very lucky to work at Fred Hutch, where I get to work alongside faculty that are researching these questions actively. And what I love that I heard one of our scientists say the other day when talking about hormone replacement therapy, and if that's putting, menopausal risk, putting people who are like perimenopausal around the time of menopause, like at an increased risk for heart disease, cancer, is because it's, so good for lowering symptoms for so many folks. So like, what does this mean? And what one of the scientists said was, she was like, we don't care. And that sounds bad. And what I mean is we care about our patients. We don't care about the answer because we don't have a preference about whether it's good or bad. We just want to know if it increases your risk or doesn't increase your risk so we can share that with the public and figure out how to balance those risks. She was like, we're not trying to find a yes or no answer. We're just trying to find the correct answer, the correct data to inform the way we help our patients make decisions that feel right for them,
I think here's another answer question for you. So Coffee Rocks points this out, and this is a really good point on this slide. If you have patient 1 starting at their period at 11 and patient 2 starting it at 17, if they both have the same number of eggs, let's just say for the hypothesis, then they all should have the same number of years that they menstruate. So why would there be a presumed difference then? Is it because of like the age at which you're being exposed? Is there like a critical window where you're more susceptible and it drives you a little bit more into the risk zone? Like how does that play in? Or do we not know yet?
That's a great question. So not necessarily. So not everyone necessarily has the exact same number of eggs because there's really no way to firmly quantify. For example, I was assigned female at birth, identify as female. I have no idea how many eggs I have. I've never checked. No doctor has ever told me. I have no idea. And most of us don't actually know. And we also know, from the best of our understanding, most women have more eggs than they will ever go through in their menstrual cycles. And so you're going to stop menstruating before you run out of eggs. So it's a great theory. You would think you stop menstruating when you run out, but there are a lot of factors that tie into menopause that can cause early menopause, late menopause. There are a variety of different reasons. And the other thing that I think is tricky is when we talk about healthy and unhealthy, those are such big terms to define really complex things. Is it healthy to have a period at 11? Is it healthy to have a period at 17? Depends on your body. If you are the kind of kid who loves track, and so this kid is just running around all the time, constantly running, constantly working out, and has a pretty low body fat content, your body needs to have a certain level of fat to menstruate because your body's like, if we don't have a certain level of fat, we don't have enough stores. We don't have enough energy to grow a fetus. And so we're not going to start menstruating because we don't want to be fertile. And so if that person doesn't have enough body fat content, they might not get a period until later. It doesn't necessarily mean they're unhealthy. It just means that their body is in a different environment and moving at a different timeline.
Right.
That's in alignment with their lifestyle, their body. So
presumably you could start earlier and you're just getting like 6 more years of periods and cycling than the other person, and that's what's adding to your risk factor. So it's not like we start with 100 eggs and we just go through that many cycles, and once we're done. It's you're going to be storing more. The quality is going to be different throughout you age. You're going to be affected by different factors as you age, external, internal. And it's just you're giving a larger buffer period during which you can be having that estrogen negatively affect you.
There's just higher levels of estrogen. The body's exposed to estrogen more. We know that estrogen increases exactly like in the chat. Yeah, melamine. Yeah, exactly. The longer you live, the greater your cancer risk. The more the estrogen exposure. The general rule of thumb is that can increase breast cancer risk. Now, again, when you modulate hormones, sometimes people go on hormone supplements that actually lower their overall hormone levels. Sometimes people go on hormone supplements that raise them. Like all of these decisions are so personal. And so they're all things that should be discussed with your doctor and discussed in the context of your life and your goals. What does healthy look like for you right now at this moment in time? What is your family history like? What is your genetic makeup like? What is your baseline risk? And how much are these things going to influence it? Because one of the other things that I think is important and we've said this multiple times in multiple different contexts, but again, cancer is not about morality. I remember one of the things that my mom said, and again, I'm very lucky that she's totally fine. And you know, she had great treatment and went through it and she's totally fine. I remember one of the things she said to her oncologist, like shortly after being diagnosed, she was like, I did everything right. And even the things that are out of my control, I did right. She's like, I have no family history. I got my period when I was like 17. She was like, I exercise, I eat decently. She's like, I have tiny breasts. There's not even that much tissue. She's like, I don't know. She's like, I had kids. I had 3 of them. I breastfed. I did all the things that are supposed to lower your risk. I have criminally low estrogen levels. Like had to have like hormonal help to get pregnant. She's like, I should have never gotten this. And they were like, but you did. Because sometimes you do everything right and the thing still happens, you know, which is why we have screening and why we have, you know, treatment and all of that. But yeah, again, I just think another important thing to remember, because I think so many of us hold ourselves to these standards of like doing everything perfectly, but some things are out of our control, you know?
I think we like to believe that we're in control of everything, right? I know I do. I really like to believe that. But I mean, it makes sense of what your mom was saying too. Like, hey, I've lost, like, but why? I didn't do anything wrong. And then the morality comes into like, I was like, right. I know I've seen it with patients too, where it's like, you know, you have the medical side of things where I've done everything right, but then it's like, I'm also a good person. Right? You start like negotiating there of like why, and it just goes to show that this doesn't go in any particular direction. Just everyone's a target. Yeah. And Misadventures in Astro, thank you for the $25 dono. Ooh. Guys, 340 our first day. We're getting close. Maybe we'll get to the halfway mark on day 1.
Also, what my brain does, and I realize that like everyone's brain works differently, but like when my brain sees $25, my brain's like, oh my God, that's 1/4 of $100. And $100 is 1/10 of $1,000, and $1,000 is so much money. My mind instantly like converts every sum to like a larger sum. My mind's like, this is amazing. Like so exciting.
I love that. Yeah, the 25. Yeah, I get the quarter, but my pessimist comes in and I hold back after that. You know, I hold back after that.
Honestly, that probably protects you. My friends and I were talking about this. The line between optimism and naivete is almost invisible. Like every morning, dude, I wake up and I read the paper and I go, another bad thing. I really thought we were going to start being better today. Like every day, I'm waiting for the world to be better. And every day I text my friends and I'm like, once again, bad things are happening. And they're like, you really got to wake up. Like you're a full grown adult.
That's why I just don't read the news. I mean, I don't know if that's any better, but it's like, then you can't be disappointed.
Honestly. Yeah.
And Misadventures, thank you for the Gigantified for Science emote as well. Thank you, Misadventures.
Okay, the next slide I did specifically for the colony because I know that we are science lovers here. So these are the 5 most common types of breast cancer. This is from a 2023 publication. So things might have changed in the last few years, but to the best of my knowledge, this is still pretty true. And you'll see here that the top 3 most common, as well as the ones with the best prognosis, are what's called HR positive, hormone receptor positive. And you'll see they say ER positive, estrogen receptor positive, driven by estrogen. And you'll also see that all 3 of those can be treated with a targeted therapy called tamoxifen. And that's because tamoxifen actually blocks your cancer cell's abilities to perceive and use estrogen. They bind to those estrogen receptors and therefore inhibit estrogen as a growth signal. And so that's why there's one of the reasons why these kinds of cancers have better prognosis, is that we have this really effective treatment. 4th down, you see HER2 enriched cancer. So these are hormone negative, HER2 positive. And these can be treated with something called Herceptin. Herceptin is another targeted therapy, but it specifically binds to something called HER2. HER2 is a protein that gets overexpressed on these cells and also helps to drive their growth. It's another sort of way that they grow faster. And so by binding these HER2, they inhibit that cell's ability to get growth signals and therefore inhibit their growth. And then what's harder is the triple negative cancers. These are cancers that don't express hormone receptors and they don't express HER2. And so we don't have very good targeted therapies. BRCA1, BRCA2, we talked about earlier, genetic mutations of these genes are more likely when folks are born with these genetic changes to cause this triple negative cancer. Those changes are involved in double-stranded DNA repair. And so we do actually know that while these genetic changes make these folks more likely to develop cancer, when they do, these cancer cells are actually also in a weird way more fragile because they're worse at repairing their DNA. So it makes them more likely to become cancerous because they're worse at repairing their DNA. So they're more likely to acquire the genetic changes that make them cancerous.
And then more and more changes as well on top of that.
Exactly. So they're getting real freaky real fast. But we also know that they're worse at repairing their DNA. So if we can damage them with like radiation or another form of double-stranded DNA damage, then they're going to be bad at repairing themselves. They might die faster. So we can actually something called PARP inhibitors, PARP inhibitors, which actually make the cancer cells even worse at repairing the double-stranded DNA damage. They sensitize them even more. So folks with these genetic changes, we often do use this specific kind of medication called a PARP inhibitor to make their other medications more effective.
So it's a lot, like Melemony said, it's that individualized and personalized care that's really needed for each of these different kinds of cancers. Because I know it used to be decades ago, right? It's like cancer is cancer is cancer, but it's very different, right? Based on like where you're getting the mutations or what are the factors that are causing it.
My platonic, intellectual, deeply respectful crush, Siddhartha Mukherjee, one of his books, The Emperor of All Maladies, he talks about sort of the history of cancer treatment. In the beginning, they were just like, I guess, cut it out more. Like they would just remove as much tissue as possible. Like to the extent that for treating breast cancer, they're removing part of the upper arm. Like they're like, it's got to be somewhere.
Oh, wow.
And so that it was like a plant with roots.
Yep.
They didn't realize that sometimes cancer can actually break off and metastasize and spread to other parts of the body where there's no clear link. And so it was one of those things where they were just kind of exploring, trying to figure it out. But the thing, I forget who said that, Melemony, I can't see it in the chat, but someone who was saying that should work at Fred Hutch, because what you described, that personalized medicine, it's called precision oncology, and it's kind of our thing at Fred Hutch. And it's using a person's genetics and personal history to help guide their treatment, to tailor their treatment to them and to their cancer, because every person's unique. All cancer is genetic, it derives from their cells. So every person's cancer is also unique. And so they need to be treated very specifically to help increase our likelihood of killing the cancer and sparing the healthy cells. If we can create treatments that only hurt cancer cells, if we can create treatments that go into the body and leave healthy cells alone, completely ignore them, but actually selectively kill cancer cells, we're going to reduce side effects, because the side effects come when you've got healthy tissue dying. So that's really the name of the game now.
That was why we were all excited about this axolotl paper on Fridays, because that's what that mucus did. And that was without adapting those molecules in any way. It was just we synthesized the antimicrobials on the skin of this axolotl and put it on breast cancer cells.
There's a podcast. Again, I love plugging Fred Hutch, but occasionally I do got to bring in a third party. This is a podcast, which Fred Hutch, we do actually make a podcast. It's called Health Equity Now. It's fantastic. But this is not our podcast. This is Radiolab, which some of you may be familiar with. It's an NPR podcast. But it talks about, it's called The Shark Inside You. And it talks about a lab that is exploring these antibodies in sharks that are more flexible than our antibodies. And so we think we can train them to fight cancer, but also to help fight Alzheimer's disease and a variety of different other health concerns, including potentially autoimmune diseases. And it's fascinating. And my dad sent it to me in the classic dad way, where he was like, I found this article, period. I thought you might enjoy it, period. And I was like, thank you, period. But
this must be a dad thing, because my dad sent me one last week too, like moths using the moon to fly and navigate, and he's like, thought you might like this, but he goes at ... and I'm like,
what? Oh, classic. Yeah.
What do you want me to ... on this one, Dad?
Dads from a certain generation are like, there are 3 things I can know about my child: the name of their partner, their job, one hobby. And they're like, those are the 3 things I will communicate to my child about. So my dad to my brother is always like, how's your wife? To my sister, he's always like, how's your dog? Her dog is her hobby. And to me, he's always like, how is science? Like, it's the parent thing. Yeah.
It's like,
classic.
Bugs. I don't know what you do anymore, so I just...
Your dad's like, how's the computer?
Yeah. You didn't go to medical school, so how's the failure? It's like, oh, well, that was a fun one.
Oh, that's relatable. That's relatable. And they pretend they don't care, but like...
Oh, no, he doesn't. Oh, no, he doesn't. Oh, no, he doesn't pretend on that one. It's like, you wouldn't have this insurance issue if you'd had gotten a good job.
I do remember one time, a family member who will remain unnamed, when I finished genetic counseling, was like, wow, so you did a master's and you worked in research for a few years? I was like, yeah. They were like, if you just gone to med school like everyone thought you were supposed to, you'd be done by now. I was like, thank you. Glad to know that we're not alone. There's two of us.
I'm glad we have an even deeper connection now, Ellen. We're both disappointments on one side of the family.
There's got to be one, though. Like, there's got to be, I don't know if you have siblings, but there's got to be at least one sibling.
No, my sister's finished med school. She's in her residency right now, so she didn't fail the family. And my brother's still in college.
You're also perfect.
Yeah. And then my younger brother's still in college, not going to go to med school, so he already failed the family. So, we've got to...
Okay, but you're still a doctor, and your partner is also a doctor.
But not a real one.
Right.
And now we're trying to communicate science. Helen, I don't know if you knew this, but happiness doesn't pay the bills.
So true. And no one respects you if they don't know what you do. So...
Yeah. What do you mean? You talk to people on the internet. Is that AB Trube? Thank you for the $10 dono. 350 out of 1,000. Thank you all very much. AB Trube. I almost read it as a butt tuba, which is one of our regular friendos. That was not a...
Here we go.
That was not just like a Freudian slip. We do have a community member named Butt Tuba.
Okay. Yeah, that is important context. Yeah.
I know, Mel. I do. Same with my children's futures as well as all owed. Mel Emily, I don't know what I was thinking of you. I'm sorry. And Chillian Willie, well, I win stickers and magnets, so it worked out for me. Okay, so different kinds of breast cancer, different kind of personalized treatments. Different kinds of mutations inputs. We'll guys, I'm going to share the references that Helen has included with us in the Discord. If y'all have questions about like where these are coming from, again, I'm just going to take out the references and put them in the mention on stream Discord. So it won't be the slideshow, but it'll be all the different points that we're talking about today. And I did link that Radio Lab for us in the Discord as well.
Fun episode. I'm also going to share really quickly that one of the other things about like targeted therapies and like precision medicine is we have a really cool scientist here at Fred Hutch, Taran Gurjal. He's amazing. And he leads is it just called the Rare Cancers Initiative? What is Taran's group called? Is it just called the Rare Cancer Initiative? They usually have a good name. Yes, TRACER. TRACER stands for what do you stand for? The Transformative Rare Cancer Initiative. And what's crazy, what's really cool that he's doing is that there are a lot of cancers that don't get studied as well for a lot of the reasons we were talking about before. And one of the things that's hard about rare cancers is that there's often not a lot of funding because people don't know about them and they're not going to fund things they don't know about. And there's not a lot of data because our sample size is so small. So what his team is doing at Tracer is they're taking drugs that have already been FDA approved and they're using our new understanding of technology and human biology to test, not in people, but in model organisms and using these like specialized computers tools and technology, including machine learning models, to assess if these FDA-approved drugs might work in other cancers because they might actually not be, they might be, a little bit of what's called like chemically promiscuous or able to actually bind to multiple receptors. So they might actually work in other cancer types, which is super cool because then we could treat rare cancers without having to have specific drugs for those cancers.
And that's similar things. There's the Undiagnosed or Orphan Disease Network run out of Baylor, where they're integrating mutations in kids that are, again, it's like 1 or 2 kids a year. So it's not enough for you to actually research on what to do and how to fix it because of the money, but off-target effects of drugs to repurpose once you figure out the genetic mechanism at play. It's really cool that there's these really clever people at work, kind of almost bypassing and utilizing drugs for something else. And so there is a treatment for these patients. They're not just left with nothing.
Exactly. Because it takes, I forget the number off the top of my head, I'm going to get it wrong, but it's like $10 million or something to get something through clinical trials for FDA approval. 10 million feels conservative. I forget. I'll need to find the exact number, but it's a very non-trivial sum.
I think even more because if you take into account like all the ones that didn't pass through for the one that did,
right?
It's like some absurd amount of money that it comes. Yeah.
No, it's crazy. But yeah, so I just wanted to share that fun little tangent because I think that's also what's clever and important about healthcare, right? And it comes back to what you and I are talking about, like science communication, but there's also medical communication in the form of accessibility. If we have all these treatments, but no one's using them, then what's the point?
Right.
If we have all of these drugs, but we're not using them to their full advantage, then what were all those clinical trials for, And so I think what's great is that we have these scientists at Fred Hutch that aren't just like, I'm going to understand breast cancer, I'm going to cure breast cancer. They're like, I'm going to understand how to make sure once we have the understanding, once we have the drugs, we're actually getting them to everyone that could possibly need them.
Right. Not just like that niche target that it was tested for.
Right.
But, I mean, because you've already done the safety testing there, right? So you know it's safe.
Right.
Or
Right.
what the side effects are. So then it's just like, well, now instead of just treating this, I can treat these other things too with it.
Exactly.
Yeah.
Exactly. Yeah. Yeah. No, super cool.
What's
All
even
right,
more
next one.
confusing and cool, Helen, is this next one.
Yeah, I want to end with a fun one. All right, so this is the last little question we have, but I want to end with this one because this is like a hot debate. At least it was in my very liberal undergrad.
So could you, for a simpleton like me, define what is natural deodorant versus conventional antiperspirant? I don't know. Now I don't know now.
Someone did not live with rabid vegans in college, and it shows. Luckily for you, I did. So natural deodorant doesn't have aluminum in it. Natural deodorant, frankly, I don't know what's in it, but natural deodorant is kind of like perfume for your armpits that lasts about half an hour, maybe. And it's usually, it supposedly has other things that can reduce your sweat, but usually the natural deodorant doesn't have antiperspirant in it, so it doesn't make you sweat less. It just like makes your sweat hopefully smell a little less rancid. Conventional antiperspirant usually has something like aluminum in it, which helps your body to actually sweat. So it's actually an antiperspirant as well as having scent that is like smelling better.
Okay.
Again, I'm, wording it sassily for the sake of sassiness, but like people should do whatever they want, whatever makes them feel comfortable and safe. But a lot of the reasons that folks moved to the natural deodorant was because there was this theory that it increased your breast cancer risk. Because people were like, people are more likely to get breast cancer in this part of the breast tissue, which is closer to the armpit. Could it be because the aluminum is impacting your breast cancer risk? So I'm curious.
So the idea that it would be traveling through like very close to the bloodstream or something because of tissue.
Exactly. This was one of the theories.
All right,
Yeah.
I'm going to say natural deodorant against the hippies is more likely for cancer.
Ooh, you think it's more likely for cancer? Tell me why. Tell me everything. I love this.
I got all right, because this is going to be a stretch, but by having your pores provide, sweat, that's a chemical reaction, which is likely then to cause free radicals to form, which is likely to cause DNA damage. And so by preventing it from happening, you lower the likelihood of it.
Okay, that was fun. I liked that. Okay, that was fun.
I
liked that.
Against the hippies.
Spoken like the coolest kind of doctor.
No.
Okay, other people are saying, going to conventional puts you at a higher risk.
I like Mr. Brain was like, it was fun, but wrong.
Okay, all right. Okay, you can go to the next slide.
All right, I bet I was wrong.
Effective.
Curses, she got us.
Gotcha. Yeah, this one, no data has proven that traditional deodorant causes an increased risk for breast cancer or the natural deodorant. Like, no data has been compelling enough to say that like you're at an increased risk if you use either. The like prevailing reason for why we think more people get breast cancer in this part of the breast is that there's more breast tissue there. They're like, there's just more volume in the part of the breast that is like closer to that part of your body. So like, it's just a numbers game. Like more women get more women get cancer in that part of the breast because that's where most of the breast is. So they were like, it's like going fishing in the lake and being like, oh, I caught it in the body of the lake instead of right here on the shore. And it's like, well, there's more lake there, And
well, then presumably you can make the counter argument too, right? Because if you're then using the natural deodorant, that's also closer to the breast. So if neither have an actual effect on it, like let's say that there isn't one, then it doesn't matter. You're just putting chemicals in proximity of your breast, and that's what it's not doing a thing.
Yeah, they're like the data says that you're probably good. You're good to go.
So. Or if at least at this stage we don't have enough data to say that it's not okay.
Yeah, the peer-reviewed sources I found that felt real and peer-reviewed published journals were like, we don't, and again, they always word it that way. They're like, we don't have enough data to say that there's an increased risk either way. Also,
we just got a $50 dono from Booyah.
Yo!
$400, Helen.
That's you guys. It's actually like really, really good. That's super cool.
Thank you. I'm going to assume that's Booyah Grandma who did that for us, getting us to $400. Guys, if we hit 500 tonight, or next stream, so we're going to be raising actively today and Thursday. Helen will be joining us on Thursday as well. We'll raffle off a Fred Hutch pin for everyone who donates $25 or more. Booyah Grandma, thank you for that dono, getting us to $400.
Honestly, 500 each night would be pretty sick. Can you imagine if we broke it? Can you imagine how sick that would be? It'd be cool.
It'd be like super sick, and it'd be worth your time then too, because poor Helen, y'all, she has a lot of things that she could be doing right now. Instead of just chatting with us about deodorant breast cancer, she could be hanging out on Clifford, she could be off dancing, She could be having dinner, and instead she's chatting us about breast cancer at SciAnts.
I like how dancing was one of the options. I love that.
I mean, it's an option, right? I'm not saying necessarily you're gonna, but like,
it's also funny because my friends and I were talking, and she was like, "When's the last time we went clubbing?" And we were like on a hike. We're like in the middle of a hike, beautiful nature, and she's like, "We never go clubbing." I was like, "Sorry, is that a thing you wanted? I wasn't even aware that wasn't a desire. Like, this has never been expressed. Where is this coming from? Like, where is this clubbing energy? No, I can't club. No, I can't. I'm not cool enough for that.
I always tell people like, oh, so and I are gonna go dancing at TwitchCon, and I'm like, Balint, have you ever been to a club and gone dancing? Yeah, once. It was terrible, and we left early, and Lita and I went to a Chinese restaurant instead. Like, nope, no. It's like, well, why do you? Because I just find the image of it hilarious.
Yeah. Here's the thing. I love dancing, but that's what weddings are for. That's what friends' weddings are for. Love that. I love it because I'm already wearing a maid of honor dress that is ugly that I don't care about. So like I can get it dirty and it's fine. This is I hope none of my many, many friends who all decided to get married in 2025, who I love, and I'm very grateful to be in your weddings, and I love you. But also, why is everyone having me order an Azazi number in a color that's not cute? I'm never going to wear it again. This is terrible. But I don't have to think about what I'm wearing to the wedding because I'm just ordering this dress.
It's one fit, I assume, like for like all the people.
Each wedding has a different fit. Actually, 3 of the weddings, same dress, different colors. So I am buying the same dress 3 times.
Is it? I learned about this when we had our wedding, but it's not only that you're given the color dress, but also the dress itself, which may or may not be flattering on the person, right? And so we gave like 3 options that were very different styles. Like they were same color, right? But like, here, this is for this kind of, right? Because I was like, oh, that could seem very unfortunate. Yeah.
So it depends on the bride. So what's really popular these days, most of the weddings I've been in have been like this. Actually, 5 for 5 so far, actually. They give you a color and a website and a fabric and like a few basic guidelines. So like floor length, no spaghetti straps, no slits or whatever. And then they're like navy blue chiffon from this website, and then you order it. I love that we got a donation talking about bridesmaids dresses.
Neil, thank you for the $25 dono, taking us to $425 out of 1K, y'all. Excellent. Thank you so much, Neil, for your generosity.
That's so exciting. That's so close. Oh my gosh.
And about wedding dress. Look, we got a rabbit hole. Sometimes.
We got a rabbit hole.
Yeah.
Okay, if you go to the next slide, I also think it'll be fun and have like fun things to talk about, because these are well-known, well-established breast cancer risk factors. And again, you'll see that I've parsed them into lifestyle factors and risks you cannot change. Sometimes people will call lifestyle factors modifiable risk factors. I choose not to use that term because I don't think all of these things are modifiable for all folks.
Because maybe you want a child and that's not really a negotiable thing. Is that a potential example of
Exactly. Because so we know that alcohol can increase your risk for breast cancer. We know that regular physical activity can lower your risk for breast cancer. Having children, especially having multiple biological children, so giving birth, being pregnant multiple times at younger ages, typically, I think it's between the ages of 18, below the age of 16, there's actually slightly increased risk. But I think between 18 and like 25, having children biologically lowers your risk for breast cancer because, again, it's modulating your estrogen levels. Breastfeeding lowers your risk. Hormone-based birth control, depending on your own personal levels and how it modulates your levels of estrogen and other hormones like progesterone, may or may not increase your risk. Hormone replacement therapy, again, depends on your baseline levels. Lots of different reasons folks can go on it, sometimes to raise, sometimes to lower. Breast implants can increase your risk for breast cancer. And then risks you cannot change. Being born female, AFAB, assigned female at birth, increases your risk because you got all the parts that can get the cancer. Age at first period and menopause can increase your risk if you have a period for a longer period of time. So earlier period, later menopause. Getting older, that's a big risk factor, but arguably a good one. I hope I get to the age where they're like, we're beginning to get worried you might develop cancer, because that would mean I've lived till like 80. So like, slay. Next, that's what I'm saying. Like right now, they're like, we're not worried about you. You're so young. And I go, thank you. Actually, they're kind of not saying that anymore, which is pretty rude. They're like, you're no longer super young. And I'm like, okay, all right, rude. Genetics and family history, can't change that, but it's good to know because we can act on it, which we'll talk about later. Personal history of breast cancer, you can't change that. Race and ethnicity, can't change that. Height, can't change that, but it can actually increase your breast cancer risk.
So is it tall or short? What is it?
I'm pretty sure when I was doing this reading, that was a while ago, but I think it's just that if you have taller height, if you just have more tissue, typically you're at an increased risk.
Is that presumably because you have more estrogen to cover?
That was my understanding. Yeah.
Or I guess too, like if you're taller, you have more cells.
That, and I think it might also have to do a little bit with the idea of hormone exposure during puberty. But okay, let me find I linked my cute little source. Okay, unhelpful. I linked a source that is a prospective cohort. Helpful, love. It's like a real paper published from PMID 217-82509. But it's just an epidemiologic study that says taller people are at an increased risk for cancer, but it's unclear what the actual mechanistic increase is.
Gotcha. I think there's a lot of like hypotheses that make sense, like even what we just kind of threw around of what could be the factor to it, given everything else that we know.
Yeah. Breast tissue density, that can increase your risk. We also know that it can increase, the reason that breast tissue density can increase your risk, one reason is because you know that dense or heterogeneously dense, as opposed to fatty breast tissue, can put you at an increased risk for cancer because it's harder to screen. It's harder to see a mass in a dense breast than in a fatty breast because the tumors are dense. And so they actually look more like your breast tissue if your breast tissue is denser. It makes it harder to see on imaging. Whereas if you have really fatty breasts, a dense spot is going to, one, feel different to you, and it's going to look different on imaging. And then certain breast conditions can put you at an increased risk, like lobular carcinoma in situ, LCIS. That's a breast condition that is not cancer itself, but can increase a person's risk for cancer. And then exposure to radiation or DES, so certain chemical exposures that are teratogenic, can increase your risk for breast cancer.
Oh, yeah. There's a lot of stuff here.
Yeah. And yeah, the next slide is basically just like, it's important that the cancer risks are complicated. Lots of valid reasons to make different life choices.
Yep.
So personally, having children, big decision. I don't think you should have kids just because you want to lower your breast cancer risk. If that's your motivation, double mastectomy is going to be the way to go, is all I'm saying.
Because that would be presumably a better means by which you can help prevent that.
It would much more significantly lower your breast cancer risk than having children.
Right.
Correct. Yeah.
Yep. Why'd you have kids? I don't want cancer. Excuse me?
I'd be like, sorry, I'm going to circle that back real quick. Yeah. So now cancer genetics.
Do we have time for cancer genetics, Helen? Because I want to be respectful of your time.
Yeah, we can go through this because this is a review for the colony.
Okay.
And we'll get to like a cute little stopping point. So it'll be good. Yeah, we're doing good. Okay.
Y'all, I like we're only through like a small set of the slides and it's been like 2 hours. So like poor Helen, just at this point, I'm sure she just expects us to derail every left, right, and center. But that's the fun part, right? Is that's the point of this being an interactive stream, is y'all can ask these questions. And if we don't get to everything we wanted to, that's okay. We got another topic for y'all on Thursday. If we don't get to everything, then it's okay too. We just get to bring Helen back and do more charity streams.
Exactly. None of this information is going to expire. In fact, we're only going to learn more.
There you go. Yeah.
It is this presentation. I've given a very similar presentation to a different audience that took like 45 minutes. And as I was looking at this, I was like, "There's no way we're going to have way too much fun. There's no way." My friend was like, "I don't know. I think they'll get through it." And I was like, "No." I was like, "I'm not going to remove anything because if we do, how fun?" No.
You'd be like,
I don't see it.
You don't know these people.
I was like, "You don't get how good this group is. Like, you don't understand how unhinged I'm going to be." They were like, "Wait, do you mean like you're real life Helen and not professional Helen?" I was like, "No, I'm real life Helen." They're like, "You'll never get through it." I was like, "I'll never get through it."
I guess one final follow-up question before we get to the cancer genetics is, if you have a double vasectomy and then follow up with implant, where does that leave with risk factors?
That's a great question, Lorraine. That's a great question. Yeah, so we know that having a double mastectomy and then following up with implants or sort of surgical reconstruction, that still reduces your risk for breast cancer, because the reconstruction, that's not going to be tissue that's driven by hormones. So breast implants themselves, without any sort of prophylactic surgery to reduce your risk, if you're just getting breast implants on top of healthy tissue, without any sort of surgical removal of that tissue to lower the risk, that can increase your risk for a variety of different reasons that are still somewhat mechanistic. Sometimes I think they have to do with like the chemicals in some implants. But the kind of reconstruction you would get following a double mastectomy performed for the sake of reducing your breast cancer risk is not going to increase your breast cancer risk to anywhere near what it would have been prior, especially because most people that are electing to have a prophylactic double mastectomy, or, a hysterectomy, removal of the uterus, or an oophorectomy, removal of the fallopian tubes to lower their cancer risks. These are typically folks who have genetic conditions like variants in BRCA1 or BRCA2, which can increase your lifetime risk to breast cancer to between 80 or 90%, as compared to that 13%. And so that risk is already so high. And so if we bring it down and then reconstruction, even if it were to slightly increase the risk, it would not bring it back up to that 90%. So you would still be in a much safer place in terms of cancer risk than before. Does that make sense?
Yep. So if the how you present is important to you, let's say like if you want to get the double mastectomy because you don't want to have breast cancer, but at the same time you still would like breasts, having those implants is a personal decision that shouldn't be influenced by that health component, because it is not going to like raise it right back up to where it was, negating what you did ahead of time.
To the best of my understanding, at least in the cases of hereditary genetics, which is what most of my background is in, correct. But it's also the kind of thing that is, again, like so many things, personal, and the kind of thing that you would discuss with your surgeon. Mm-hmm. Your surgeon who's actually doing the risk reducing surgery and the surgeon who's doing the reconstruction, they may or may not be the same person. Both of those are people you should consult about your baseline risk prior to surgery, your risk after surgery, and your risk after any modifications that you were to choose to have. Because again, it's how you present in the world, it's how you look in the world. A lot of things are really important to folks. And so they're all just such personal decisions.
Yep. All right. Cancer genetics. All right. You're our genetic counselor, Helen. What's going to give us cancer? All
right. This is going to be short and sweet. It's going to be a beautiful big picture. So we've talked about this before. All cancer is genetic, but not all cancer is hereditary. That basically means that I won't explain it. We can go to the next slide where we'll have pictures that help us explain it. Again, the colony's going to know this because you're all basically scientists, but DNA is the genetic material of the human cell. So we can think of DNA as this big instruction book. In The Song of the Cell, the audiobook that I'm currently listening to, which hot debate, are audiobooks reading? I say yes. But I love both. I simply can't choose. But one of the things that he mentions is he describes DNA as like a musical score, but without the cell, without the proteins, without all the machinery that reads it, it's like a musical score with no orchestra, which is like the most beautiful, sad way I've ever heard DNA described. And I loved it. The idea that the genes are so helpful, but a book without a reader is nothing. A musical score without an orchestra is nothing. And I was like, you're so true. Like the DNA needs the cell to act on it. I love that. If we think of DNA as a big book, if we go to the next slide, we can think of chromosomes as chapters in that big book. And that just helps our body keep our DNA organized. Again, this DNA, all the instructions that your body needs to make itself work. And depending on which chapters each cell is reading, depending on how it's using that big book of instructions, what sections it's using, what sections it's ignoring, that gives those cells different personalities. It makes your skin cells different than your heart cells, than your brain cells. They all have the exact same DNA, but they're reading it and they're using it very differently, which gives them their different skills and their different identities.
And they're reading different chapters or different pages of the chapters.
Exactly. And reading them different amounts, right? So some cells are like, I'm going to read that chapter, but like only a couple times. And other cells are like, that's my favorite chapter. I'm going to read it so much, it's stupid. And so it's like quantity, it's the timing too. Like some of them are like, I only read that chapter once a month. And some of them are like, I read that chapter every day. So many different ways of using our DNA. And the chromosomes are just one way we help organize it, because we don't want to be chaotic. We want to read the right chapters at the right time in the right cells, which means it needs to be packaged in a way that makes sense to our body, that feels logical.
Yeah.
And then within each of those chapters, we have our genes. And the genes are like sentences. And the letters used to write these genes, it's not an alphabet like we use to speak and to read. It's actually nucleotides, and there's 4 of them. There's adenine and thymine and guanine and cytosine. And they pair up together, adenine and thymine, and then guanine and cytosine. And they pair to form this double helix. And that's really important because that double helix structure that you see is essential to our cells being able to grow and divide and replicate their DNA. And then most genes, fake news, not even a little bit, many of the important genes that we talk about in science that have roles in human biology make proteins. Not all genes make proteins. Most genes do not make proteins.
I enjoy that. Wait a minute. Fake news on this one.
Super fake. Like 2% max make genes or make proteins. Most of our genes do not make proteins, but the ones that do often have significant roles in human health and disease. And each of these proteins has a special job in the body. There's one set of genes, if you go to the next slide, called tumor suppressors, which we've talked about before. Can anyone guess what a tumor suppressor does?
Go. All right, tumor suppressors, y'all. This is
you met Watson? Pretty cool.
Yeah. Nice, Kennedy.
Whoa.
Welcome in, by the way. Suppress tumors, says Kennedy.
Big brain energy. Absolutely they do. Yeah, absolutely they do. They suppress tumors. And the way they do that is that these tumor suppressors, if we go to the next slide, when they're working properly, They help our body to repair DNA damage. And because they repair DNA damage, they help to prevent tumor growth, because we know that cancer occurs when mutations accumulate and build up in a cell, causing that cancer cell to no longer behave the way it used to. Because again, if we think about that instruction manual, it's like the instruction manual is suddenly full of so many typos that you're like, I don't know what I'm cooking. This recipe is weird, but I'm cooking a lot and I'm cooking very differently. And so that's kind of the way that works. Yeah.
I like that, the cooking analogy too. And in this instance, it's not let him cook.
Do not let him cook. Stop. Bad.
Knock it off. Don't be a hipster. Stop cooking.
And that's why a lot of mutations have to occur, because your body's really good at like not letting these mutations occur. Like, one, you have DNA repair genes that help to fix them when it gets damaged. But then you also have a lot of genes that are involved in like pausing your cell when it's damaged to be like, let's assess the damage. And you have a lot of genes that are involved in telling your body, hey, we're damaged. We should die now. Respectfully, the good of the individual is not more important than the good of the state, your body says. Your body says, you are a citizen. The city state is more important. It's like Rome up in here. Your body's like, wrong, die, protect the state. And normally your cells are like, yes, please, I would love to protect the state. But cancer cells go rogue and they become like super idealistic, or not idealistic, the opposite of idealistic, individualistic. They're like, no, just me. I don't care about the rest of you. I'm going to continue being crazy.
And
so they then ignore the signals.
And to remind people, we actually had an aging scientist on a little while ago. Works at Oregon, and she studies P53. So that's one of those regulators that push the cell to die. And as soon as you mutate P53, that's kind of out the window, and the cells will continue to divide, even in spite of them having that mutation.
There's actually a gene, there's a hereditary cancer syndrome called Li-Fraumeni syndrome. And it's caused by hereditary changes. So one person is born with a copy of TP53, one of the genes that can encode proteins like P53. And they're born with this gene, it doesn't work as well. And they're at an increased risk for a variety of cancers, including sarcomas and osteosarcomas. And they're specifically at an increased risk for childhood cancers, because these cancers develop at younger ages than other kinds of cancer syndromes. Yeah. Very interesting. But yeah, we've usually got 2 copies of these tumor syndromes, and we get one from one biological parent, the egg, one from the other biological parent, the sperm. And they might be a little different because people are different, but they both work. They both protect your body from tumor growth by doing the variety of the functions we talked about earlier, including repairing your DNA. Can we go to the next slide? Oh, yeah, there they are. There's the 2 of them, little guys. But sometimes these genes get damaged or mutated and they stop working. And again, if we go with our analogy that they're like sentences, then genetic mutations are typos in a sentence that change its meaning. And so this is a little example here I have, the car was red, the car read. That's depending, like by itself, honestly, you're like, I can gather from context what that is. And so one mutation, your body's like, we can probably figure that out. And even more than that, you've got the other copy. And so your body's like, we'll just read this version. This is fine. This version works. We'll read this version. We're good. Genes can acquire these mutations in many different ways. So environmental exposures, like we've talked about, UV light, tobacco smoke, radiation, alcohol, but also errors in cell growth and division. Like as your cells are growing and dividing, genetic typos happen. And that's why age is the greatest risk factor, because there's time for these natural mistakes to build up and for the environmental exposures to build up. Because you're just living a life. Your cells are exposed to stuff and they're dividing a lot of times.
And even the 2 copies too, right? Like even if you inherited both normally at the beginning, that time factor gives you more time for them to mutate.
Exactly. And that's why folks that are born with germline genetic conditions or born with only one working copy are more likely to get cancer at younger ages, because it takes less time for them to accumulate, because they already have one copy that's mutated.
So you only need to mess up one of them now, and then you're...
Exactly. And that's what the next slide says. So if one copy stops working, that's fine. You've got a backup. But if both copies get lost, cancer can develop.
Yep.
Yeah. But we have other things. We'll to avoid ending on a bummer, we'll actually skip ahead real quick. If you go to the slide that has Ken from the Barbie movie on it.
Oh my God, where's BitGamey? BitGamey is a game developer in this community, and he loves the Barbie movie.
Yeah, me too. It's actually my dad's favorite movie.
Yeah, he's a dad too. He loves it.
Yeah. I think dads love the Barbie movie. Do you love the Barbie movie? It's a good movie.
I enjoyed it, yeah. No, I enjoyed it thoroughly.
It's no Gattaca, but it's good.
Oh yeah. No, I mean, the I'm Just Ken song, you can request stuff on BitGamey stream like songs. We always request the I'm Just Ken song and have it just play throughout the background.
It's a great, I'm not going to lie, it wasn't on my Spotify Wrapped, but I was genuinely worried it would be. I don't know about you, My Spotify Wrapped is always humbling. It's like, once again, you listened to so many movie soundtracks that you have not seen the movie for. I'm like, okay, really just calling me out here, Spotify Wrapped.
Lita had seen this with my sister, and she was like, I don't know if you're going to like this movie. And I was like, no, let's watch it. So we watched it at home. I'm like, oh, this is hilarious. I was just dying laughing for so much of it. I was just like, this is hilarious. This guy's great.
It's so good. I love it. It's a great movie.
Even Will Ferrell did all right in it,
I'm not a huge, I know nothing about the man as a human being, but I'm not a huge fan of his comedy.
Yeah.
So I was not expecting to love him in that, but yeah, he was fine. Again, I always feel silly saying that about like actors that are very, very successful when I'm like, they're not for me. Cause I'm like, I don't know anything about acting, but
Yeah, it's like, oh, this wine. Yes, this is a port. I gotcha.
Yeah, I'm always like, I'm pretty sure this is a red. Like, but I was like, I remember I one time went to a wine tasting and they were like, do you taste the pine and like the crushed coconut? I was like, yes.
Like, of the potpourri in the bathroom? Yeah, it was delicious.
I was like, would I want to? Would those flavors be nice in wine? No. I would recommend, if anyone's going wine tasting, again, in moderation, because we do not increases our cancer risk, but if you're going to a wine tasting, something that's fun to do is to say you can only describe the wines with non-food words. So you can't say like, oh, this wine tastes citrusy, or like this beer tastes, I don't actually drink that much, so I don't have beer words. Hoppy. Hoppy's a thing. You have to say like, this wine tastes like it laughs at a dad joke. This wine tastes like sleeping outside under the stars. This wine tastes like it doesn't know how to parallel park. Like, you have to be unhinged with it. Very fun. Would recommend.
I would imagine that if you were doing that and people heard you, they'd probably be like, oh my God, like that's a really classy person right there. I've always wanted to sit under the stars. What are you having?
It's also, I do feel like it's easy to get away with not knowing anything about wine. Like, if you just take a sip and you go, oh, I feel it. If you just say something like that, we're like, oh, that's interesting. If you just say something really generic, that's a thoughtful composition right there.
It really is.
I don't know what that means, but they're going to be like, they probably know what they're talking about.
It's like, did you see her face change? She's clearly pondering it. She must be getting those notes of olive and pecan.
This is not a classic Chardonnay. Like, just say something dramatic and they'll be like, sure. You're like, it's not a Chardonnay at all. Like,
ma'am, it's a rosé.
One of my friends really knows nothing about wine. We went to a tasting for a friend's thing, and she was like, this one has bubbles. We're like, good job.
See, that's my feel on it too. That's well done.
Yeah. I was like, you're fun. Yes.
All right. So why we got Ken? Why we got? Are we Ken enough? Is this like you come out and telling me that I'm not really Ken, because really here at the colony I'm just a 1 out of 10?
We're all Ken.
Okay.
We're ending with Ken because I don't like to end on a bummer. And I feel like ending with like, cancer comes for us all if we live long enough, is like kind of a bummer and also not helpful. But what is helpful is knowing that, first of all, there's ongoing research on how we can lower our risks. Thank you, Fred Hutch. But also there's screening that currently exists.
Okay.
So in general, screening for the general population, if we go to the next slide, at age 25, you should begin your clinical breast exams every 1 to 3 years. So when you go to your doctor, every couple years, your doctor should perform a clinical breast exam. This should be a doctor you feel safe and comfortable with, first and foremost. And it should be a doctor who is actually trained in giving these. So for some folks, that's their PCP. For other folks, that might be a specialist you see regularly. But it's a healthcare professional who's trained in actually examining the breast usually it's just physical clinical breast exam, who can actually feel properly for any sort of lumps or signs that might indicate breast cancer. And then there's also practicing breast awareness.
Sorry. My camera froze. I had to unfreeze myself.
I liked it. I thought it was whimsical.
It was very, very, very shocked. Oh my goodness. Makes sense. So pre-screening and screening with someone who you're also worthwhile and feel safe with. And we got a raid too from Negative CPU. Raiders, welcome on in. Negative, how was your stream today? Guys, welcome. Make sure to go follow the lovely Negative CPU and Positive CPU, the significant other, and the megabits, the megabytes, the little kiddos of the whole computer family. Guys, how was Super Mario 64? Let us know. Raiders, welcome in. Tonight we're doing a special charity event with Fred Hutch Cancer Center. Helen is here with us. She works at Fred Hutch, and we've been chatting about breast cancer tonight, about various means of diagnosing, screening techniques, the background genetics of it, and everything that kind of comes in terms of like risk factors that maybe wouldn't have thought about, like wine drinking and, well, not so much the deodorant, but a lot of different factors. So guys, welcome on in. Feel free to share anything and everything. Again, we have a goal of $1,000, and we have Helen back next Thursday, or this coming Thursday as well. We're having her 2 days this week as we're raising money for Fred Hutch. Again, guys, welcome on in. Feel free to share anything and everything, and I hope you all had a great stream.
Ooh, Mario 64, fun.
More importantly, my chat is unhinged and made it hard to breathe from laughing so hard. See, now that sounds like a good stream.
The best always are.
Yeah.
I remember one time having a conversation with a friend, and she was like, I feel like we're on so many tangents. And I went, bestie, that's a conversation. Like, don't apologize. Like, I love getting to the end of your story 10 hours later. Like, we're fine.
That's right. And if you're laughing all the way.
Life is so hard. Let's have a little giggle where we can. Come on now.
Yeah. Oh, yeah. And like we said, we were chatting earlier, y'all, about being disappointed in the news. And so we need to make Helen laugh tonight because she keeps insisting on reading the news.
I know. I'm one of those freaks who's like every morning is like, I should probably look at this. I never learn. But what I do learn is that we're constantly updating our screening recommendations. So the age 40 is relatively new. The general recommendation didn't used to be for everyone to start getting mammograms at age 40. But now we're recommending annual mammograms for everyone at age 40. But folks who have a family history of cancer, a known genetic condition that puts them at an increased risk for breast cancer, or heterogeneously dense or dense breasts should consider extra screening or screening at earlier ages. People often want to ask,
Fishman, thank you for the $50 dono, taking us to 475 out of 500.
You guys, we're so close. What happens at 500?
We raffle off a t-shirt.
They're really soft. Is it the navy one?
I don't know. I just know it's a t-shirt. I know it's a Fred Hutch t-shirt.
I think I know which one it is, and it's really cute.
And that'll be for anybody who's here can enter for that. The pins are for anyone who donates 25 or more. That will raffle off after the charity's done.
Oh my God. This is so close. I want to hit the halfway mark. I want to be halfway. I want both to be half. I love clean numbers. This is very exciting. Yeah, watching news online, that's smart. I do occasionally read like a paper. Like I go buy a paper for $1.75 from my local grocery store, and I read it while drinking coffee. And I'm like, is this how people in their 60s felt in the 60s? Like, is this, what, am I channeling my grandmother? Is this it?
Well, what kind of coffee though?
Oh, like I'm not, in the same way that we were saying that we're not like wine connoisseurs, I'm also not a coffee connoisseur. Because I live in Seattle, I do, when I was in grad school, I exclusively drank Folgers because it was the cheapest thing I could find. Now I do drink real coffee, but I do buy ground beans, and it is different every time, whichever one's on sale. Right now, I think it's like Fidalgo, which is like a local coffee roaster, and it's like the medium blend. And I drink it black, and I make it with my little pour over thing. And I got one of those like aluminum, like stainless steel, like pour over things because it's supposed to have like the least waste, all the things.
Nice. And then just a Fishman, thank you for the $5.27 because you love whole numbers. Thank you, Mr. Fishman. $5.27 into the pot we go. $4.80.27.
Amazing.
Thank you, Fishman. Werewolf had a question if you've ever dealt with fungating tumors before. Is that something that we can maybe talk about like on another stream when you come by, like fungating tumors? I don't know. I know we're not prepped on it right now, but there might be if there's any research being done on it.
So I did come prepared with my notebook and my glitter pens because I respect all of you. And so my youthful audiences and my extra fun audiences get the glitter pens. And so glitter pens. Fungating. I'm actually not familiar with the term. So that's not to say that there's not ongoing research at Fred Hutch, and there's not to say that there's not a relevant link to genetic counseling or to cancer genetics. Just that I'm not familiar with it.
All right. So Werewolf, we got you in the book.
Yeah.
Is it a purple glitter pen by chance?
This one is purple. I also have, no, guys, honestly, I'm so invested in Fred Hutch. It's like gross. Like I give myself the ick. I'm like, please, it's just a job. Stop being such a freak. But like the more faculty I meet, the more I'm like, I need to protect you and your work and your beautiful mind. I'm like, I must take care of you. They're so smart. They're doing such big work. Like, I feel like someone was like, hi, take care of Gregor Mendel's lab. I'm like, stop. The stakes are too high. Their pens are Fred Hutch colors. And also pink, because I like pink.
Well, and then purple too, because we're on Twitch tonight.
Yes.
And then you don't by chance have a blue glitter one, do you?
Yes.
That's because Twitch Ambassador blue, right? Come on.
Obviously. Yeah. Twitch Ambassador. Also because I knew it would go with your shirt. And I went, I'm pretty sure he's going to wear blue. I should have a blue glitter pen. Yes.
The connection that Helen and I have is pretty S tier right there.
Yeah. If you know that your parents wanted you to go to med school and you didn't, there's a special bond there. There's not that many of us, but there's enough of us. We're a fun group.
We're enough of the disappointments tied together. It's not disappointing anyone, y'all. Be who you want to be.
Be who you want to be. I also believe a disproportionate number of us. I think the Venn diagram between middle children and us is pretty. I think it's close to a circle.
I was first child.
Whoa, surprising. That just means you're cool.
Yeah. I got so far, Helen, as I got into med school and I actively chose to not go. And so I'm like the ultimate disappointment.
That self-awareness to say, actually, I'm going to get a PhD and contribute to research and make the world a better place by spreading science. That's actually such a bold choice. Are you kidding me? That's amazing. That's the right path. That's self-awareness, altruism, and belief in humanity. Are you kidding me?
You seen the movie Dodgeball?
No.
There is a scene where they're commenting on the dodgeball tournament, and there's a guy that's like, you know, they take off their best player or something. He's like, "Oh, it's a bold move. Let's see if it pays off." And the voice in my head saying, "Yeah, son, it didn't pay off. You still suck."
No,
Jesus.
It paid off. That voice is bad. We don't like that voice. Get it out of there. You are a doctor who is married to a doctor who has a daughter who could pass the MCATs right now. I don't know how smart your baby is. We haven't talked about his intellect levels yet because he's a baby. But like all of this, amazing. You have 6 cats, all with cute names. You're a Stream for Fred Hutch ambassador. Like, please, you're the coolest person in the world. Please, come on now.
Well, and plus the Raiders that we just got, the lovely Max Money, AWA, coming in hot. Thank y'all for the raid. How was Minecraft tonight? Raiders, welcome on in. My name is Balint. I am 1/4 of the SciAnts stream crew. The other 3/4, my wife Lita, and our 2 kiddos. Today we're joined by Helen Anderson of the Fred Hutch Cancer Center, and we are raising money for Fred Hutch Cancer Center and cancer research. Welcome on in, you guys. I hope you all had a great stream. Again, we're at $480 out of our $1,000 goal. We're doing 2 events this week today. And we're also doing a special event on Thursday as well, but we'll have the tally running for the entirety of the week. But we're chatting breast cancer tonight, and we're rounding out our discussion with Helen on a positive note about screening techniques. So because we didn't want to finish, on just a somber note of here's some tumors.
Yeah. If we go to the next slide, we were talking about ending on positive notes. So we talked about 25, we talked about 40 mammograms. And then a lot of times people are like, oh, how would I know? It would be something your doctor would help you figure out. Like, you yourself are probably not equipped to determine what your own breast density is like, but doctors can use imaging to help you figure out what your breast density is like. And then if you go to the next slide, you'll see that we have lots of different ways to help folks that have different breast densities screen for cancer. So all of these are available at Fred Hutch, but all of these are also available at a variety of other cancer care facilities. Not everyone's in Seattle. That's totally fine. You can get these at many healthcare facilities. So there's the whole breast ultrasound, there's digital breast tomosynthesis, contrast-enhanced breast MRI, contrast-enhanced mammography, lots of tools. And screening for the general population also includes what we talked about before, breast awareness. So be aware of any symptoms of breast cancer, basically changes in your breast, and just know that. So yeah, these are the big things, kind of less of a bummer to end on that. If you guys want to do a really quick example case, we can. It's totally up to y'all.
It is up to you, Helen. You're the one who hasn't had dinner yet.
No, let's do it. It's a short little cutie we love. And it uses the name Antonia again because I was making it colony specific.
Perfect. Thank you, Helen.
All right. So 23-year-old Antonia, in this case, she's a human being, presents to genetic counseling, so my division, with a family history of breast cancer. What do you see in her family history that looks suspicious of hereditary cancer? Hereditary cancer being an increased risk for cancer because you're born with a genetic change that makes you more likely to develop certain kinds of cancer.
Looks like the maternal lineage keeps getting hit.
What about it? Yeah, keeps getting hit with anything suspicious?
Cancer. Yeah, just in general. So we have 2 different ovarian cancers with 2 different mutations, and then 2 different instances of breast cancer, again, with 2 different mutations, it looks like.
Yes, all that is correct. Yes. And we see in 3 different generations.
Yep.
So it's moving through the generations, suggesting an inheritance. We see ovarian cancer, a rare kind of cancer. And we see these diagnoses at young ages. Ovarian at 49. Actually, ovarian at any age is suspicious because it's a more rare cancer. You also see breast cancer diagnosed at 42. So any kind of breast cancer diagnosed under the age of 50, it's going to be a little suspicious. We see breast cancer diagnosed at 38, also very young. We also see, again, ovarian and breast together on the same side of the family. Those two cancers together are suggestive of something called hereditary breast and ovarian cancer syndrome. So it's a pattern of cancers that is also suggestive of a hereditary risk. What some people point out that you might see is that we see one of the gentlemen here. So typically folks that are male or assigned male at birth are typically depicted as squares. Folks that are female, assigned female at birth, are depicted as circles. Some people notice, okay, it looks like there's a daughter in our third generation who had breast cancer, but neither of her parents had it. So what happened there? It's very possible, likely, that if there's a hereditary change in this family, she did inherit it from her father, but her father has not displayed cancer for a variety of reasons. One could be that he will one day get prostate cancer and just hasn't developed it yet because age is a great risk factor. Two, we know that cancer syndromes display something called incomplete penetrance. So not everyone who has the genetic change that puts them at an increased risk for cancer will develop cancer. So incomplete penetrance. And we also know that even though changes in some genes like BRCA1 can put you at an increased risk for breast, prostate, pancreatic, melanoma, mostly with BRCA2, there's an increased risk for breast and ovarian even more than the other kinds of cancers. And this man most likely does not have a breast or ovaries.
So he's carrying the likelihood factor for it, but maybe for a variety of reasons, he's not susceptible to it at this current stage.
Exactly. Lots of reasons. Yeah. Yeah.
And this isn't just for the party people. This is the only way that you could get this kind of cancer, right? It doesn't have to be this genetic component to it. This is just an example of when it is happening.
Yes. So again, only about 5 to 10% of all cancers involve some kind of germline or inherited genetic change. Most cancers, about 70%, if not more, are what we call sporadic cancers. And those are cancers that have nothing to do with the genes you were born with, but have more to do with changes that have accumulated over time. Environmental factors, just cell division errors as we go through life. So a very small subset are associated with these changes that we know of that are well understood and well documented changes that put you at an increased risk from birth for cancer.
Yep.
Yeah. So you got all the things, all the big things. And like you said, the fact that it's all on one side.
Yeah.
A lot of times people come to a cancer genetics clinic and they'll be like, oh, I'm really worried. I'm at an increased risk for breast cancer because, my sister had breast cancer. And, that's scary. And that is so valid. And better to come to care and find out that, you're not at an increased risk. Because a lot of times folks will come in and they'll say, oh, I have this family history of breast cancer. And then when you actually look at the family history, you realize that it's not as much as you thought. 1 in 8 people, yes?
Glued, thank you for the $19.73 dono, getting us, Helen.
Stop.
To $500.
Well, I was rambling. I love.
Thank you, Glued with Gold, for that dono, getting us to 500. Should we, Helen, do we stop everything and do a shirt raffle now?
We stop everything, we do a shirt raffle. We stop everything.
Yes, ma'am. Let me fire up the raffle board and we'll do a t-shirt raffle. Guys, what do you want the keyword to be, Helen?
Oh my gosh, what? There's a keyword? I don't know. Should it be, I don't know. What should it be? The stakes feel so high.
I mean, we could just make it raffle. We can make it really easy.
We should make it pickle in honor of Munchkin's giggle earlier about the little stuffed toy.
Okay, guys, exclamation point pickle to enter for a chance to win a Fred Hutch t-shirt. Go ahead and put this in the handy dandy notebook. Get on. Yep. All right. We got him in there. And Helen, do y'all ship international? I believe so, right?
I believe so. I'm pretty sure Jackie says yes.
Okay. We've done in the past. I just wanted to make sure. Guys, get up on in there for the pins. We will raffle off after we've ended our charity fundraiser. And that's for anyone who's donated $25 or more. But this one we're making open to anybody within the community for a chance to win a Fred Hutch t-shirt. And if it's the same one that I have, it's a pretty fire t-shirt.
Yeah, they're really soft.
Yeah. Not pig cool Fishman. Fishman, you're already in. Fishman, coming up with silly words here. All right, guys, last call. We've got there's only a few people in here. The likelihood of winning is very high right now. There we go. Queen Call. Not Misadventures singular pickle. Oh, it's still picked you up. Misadventures, you're still in, even with the multiple pickles. All right, Helen, would you like to count us down for a t-shirt?
Oh my gosh. Okay. Should I go from 3 that feels safe?
Yeah, wherever you want.
Okay, we'll do 3. 3, 2, 1, go.
Jester Frankie.
Exciting.
Jester Frankie, congratulations on winning the Fred Hutch t-shirt. Jester, if you would not mind DMing me a shirt size, and then we will get this shipped on over to you. A shirt size, and I think I already have your address from your previous win. But yeah, just DM me that shirt size, and we'll get it sent on over to you. Thank you all very much. Again, we do have one more t-shirt to raffle off that we'll do if we hit 1K. So thank you all very much for that. Heck yeah, 500. Helen, we did it. Now, see, Helen, now to be really wildin', we need to get 1K before you come back on Thursday.
Honestly, that would be delightful. I don't know what I can do to be even. I'm trying to think of something cool I could do, but that would be cool. I'll brainstorm. I'll talk to Jackie, but that would be so sick. That'd be pretty cool.
Stay tuned, y'all. Stay tuned. Okay. So possible.
This actually looks suspicious. So a lot of times folks are concerned about having a hereditary cancer risk, but it's rare. Most of the times we don't find a hereditary cancer risk. Most of the times cancer is just something that happens. But occasionally there is actually an inherited risk factor. And this family is looking really suspicious. We're seeing all of the things that make us really alert. So what gene, we've mentioned it today, do you think Antonia's family might have a pathogenic variant in? So a change that makes it work less efficiently and therefore puts these folks at an increased risk for cancer.
So because there's ovarian and breast cancer, right, we'd have to see if BRCA also is implicated in ovarian cancer. I've had the pleasure or displeasure, I guess, of studying NF1, and that is a transcriptional dysregulator, and that also has been shown in multiple cancers. So only because I know that is involved in multiple cancers, that's what I'm going to go with is NF1, and because there's two different types.
If you go to the next slide, you'll see a little hint. All of these are actually associated with hereditary cancer syndromes. BRCA1 causes a condition called hereditary breast and ovarian cancer syndrome. PMS2 causes something called Lynch syndrome, which is known mostly as a colon cancer syndrome. NF1 causes neurofibromatosis type 1, and HOXB13 is associated with an increased risk for prostate cancer.
It was BRCA1, Melemony. I was trying to talk myself out of it. I was like, no, surely it couldn't be that simple.
It's BRCA. It's BRCA1. Yeah. And so this is, if you go to the next slide, this is actually an example BRCA1 pedigree because it's like so screaming BRCA1, which is why it's actually kind of a red herring. Like genetic counselors are always like, what else could it be? Because like it's so BRCA1-ish. But yeah, so folks with changes in this gene are at an increased risk for a variety of cancers, primarily ovarian and breast, also pancreatic, depending on the family history, and prostate cancer. And for BRCA2, they're at an increased risk for melanoma as well, less so with BRCA1.
And is BRCA1 and 2, is that two different genes or is that two different mutational variants of the same gene?
Amazing question. They're two completely different genes. Both derive their name from the cancer they're most associated with, which is breast cancer. So BRCA, BRCA, is breast cancer, BRCA. And so they actually derive their name from that gene, but they're two, or from that cancer, but they're two completely different genes. Yeah.
Gotcha. And then,
but they both are double-stranded DNA repair.
Gotcha. And then Mel was wondering if there is a third gene that's implicated now.
Great question. They actually look at a lot of different genes. So for BRCA1, for hereditary breast and ovarian cancer syndrome, we most commonly think of BRCA1 and BRCA2 is associated with that syndrome. But there are many different genes that can put you at an increased risk for breast cancer. So it's not just those two genes. And typically, if you have a family history or a personal history, or some reason your doctors are suspicious and suspect an inherited cancer risk, they're usually going to order what's called a panel test, which is a genetic test that's going to look at multiple genes, not just those two. Yeah, great question.
So what are the next steps?
What do we think she's going to do? What do we think, guys? A couple different options, obviously.
Double mastectomy.
She could. We call that discussing and considering your risk-reducing options. Yeah, she could absolutely do that. There are a couple different options.
Or I guess preventative screening further without going that really extreme route.
Refer for higher screening. You got 2 of the 3. The third one people often forget about.
Genetic counseling, says Melemony.
Yeah, definitely that. Definitely early screening, 100%. Yes. Okay, the third one is usually kind of tricky, and it has to do with the fact that the genetics are typically things we share with our biological family.
So testing other members, right?
Yes.
Yeah.
Once you get your test results, if your tests come back positive, then we would recommend that you discuss with your family members them having testing, if that would help them inform their own screening, risk reducing, family planning, whatever options they might pursue.
Or I guess there could be to like the likelihood that it's false positive, right? Like if in your results it's this, and then you tested your sibling, what else they would also have if they're also matching at some of these components. That could be like further evidence of like where that genetics are lining up, and for them also to get into pre-screening.
Exactly. Because typically if you have a hereditary change, like if, for example, our proband, the person who presented for care, the person with the little arrow, If they come back positive, then our next step is actually going to be to want to test their mom if we can, because we're pretty sure that's who had it. And that would just really confidently confirm that, like, yes, you inherited this change from your mom. Then you want to have her brother tested to make sure that he's, aware of his own risks, his own screening options. And then you would also want to have this discussion so they could talk about, the chance that you would pass this down to a pregnancy, because you have 2 copies of each gene. Usually folks with a hereditary cancer risk have 1 copy that works, 1 copy that doesn't. So about half of their gametes, half of their eggs or sperm will have the copy that doesn't work, half will have the copy that does. There's a 50-50 chance. And so some folks say, you know what, that's fine. My life is still high quality. There's great screening. There's great treatments. I'm just going to have kids spontaneously because that's still in my life goal. And some people say, ooh, that feels like a high risk. I prefer my child not to go through this anxiety or to go through this screening. I'm going to do IVF and I'm going to select for embryos that don't have that change, so that they're not at an increased risk for cancer. So we also like to share it so that people can make whatever choices they like, their body, their genes. But there's all of those different things to consider. Yeah.
Yep. Cool.
So that's where we're at with our example case. So that's what we got. Yeah. Thank you all for humor. I feel like I was particularly unhinged tonight. I don't know if it's a Monday thing or a summer thing, but
no, I that was an absolute blast. Thank you for joining us and talking science with us and taking the questions and the absurd number of rabbit holes as we always do. And yeah, that was a lot of fun and I think really informative that hopefully will make a difference in a lot of people's knowledge about just some of the backgrounds here, because there's a lot of misinformation out there. There's a lot of fear out there, which spreads the misinformation even more.
Yes.
So honestly, thank you for your time and just your expertise in this, Helen. It's I think what makes this kind of collaboration, this kind of fundraiser really important and really unique, because it's not, you're not this, again, faceless person. You're real. You're here. You're also at Fred Hutch, interacting with the researchers. It's it's absolutely it's a pleasure to have you, Helen, as always. And we do have a final question for you. What kind of soup are you going to have for dinner tonight?
Okay, honestly, I'm not going to have soup. I was telling Jackie this. I was like, it's probably going to be 9:30. I'm going to be exhausted. What am I going to make? I was like, my special, late night, save for when you're tired kind of dinner is a child's dream. And it's so gas. It's a toasted PB&J with a sliced apple. And it's never not hit, you guys. I used to volunteer at a crisis line. So I would answer calls. And I would work the late shift because I'd go after work. And so I would volunteer from I think my shift was 6 p.m. to midnight or whatever, or 6 p.m. to 2 a.m. or something like that. But I would always get home super late. And I would always do that. And it literally always is. So if anyone out there is I haven't had a PB&J in a while, guys, do it. Toast it. It's so good.
What kind of jelly?
Honestly, right now, I think I have blueberry preserves.
Ooh, okay. Nice.
It'd be pretty good. Here's the thing. I'm not brand loyal to many things. I am brand loyal to my bougie Bon Maman, fruit preserves, because you don't have to bake, and that stuff bakes like a dream. It's so good. It retains its color when you bake it. It retains the flavor. Oh, it's gorgeous.
Nice.
Yeah.
Nice.
It
does.
What's your go-to grape flavor? Or what's your go-to flavor? I'm seeing a lot of grape. Love that.
There's some grape. There's some anti-grape jelly as well. Raspberries, says Melemony.
Raspberries, great. Yes.
I'm a sucker for, there's this Hungarian brand of red currant.
I love red currant jam. Yeah.
It's like that tart to it, has that little kick to it. Oh.
Yeah.
And then otherwise apricot.
Apricot is good. I have apricot in there too. Right now I think I have Marionberry, apricot, blueberry, and I think a red berry blend.
Ooh, okay.
Yeah.
Nice.
Again, I love to bake. I have so many preserves. I have an obscene amount of flours too. I recently got a buckwheat flour. I'm well, now I have to use this up.
And I do we just had a random hype train start. It's a treasure train. I don't know what to make of it, y'all, but if we reach level 5, then it's a 35% discount for subs. I don't know what triggered that, y'all. You choose that information and do with what you will.
Well, I wish you all the best with that.
Nothing even triggered that. Thank y'all for mystery triggering. No, that sounds delicious. And I also love the fact that you told Jack, you're well, we're probably going to go till 9:30. Poor Jackie.
Oh, yeah. Jackie and I we're so in sync. Also, her wedding is so soon, which is so exciting.
Yeah, it is.
I can't believe it's so soon. And like we're doing one up, and like she's so powerful. Yeah.
And Pixie, not only thank you for the resub with Prime, but thank you for the $10 donation to Fred Hutch Cancer Center. We're at 510. We crossed the halfway threshold, Helen.
Oh, beautiful. Love to see it. Amazing.
Thank you again for joining us, Helen. We look forward to Thursday night.
Yes, I'll see you soon. Thank you. Thank you all.
Thank you. Bye, Helen.
Tell everyone to say hi. Bye.
All right, guys, that was the incredible Helen Anderson who joined us tonight. She's going to be back live with us on Thursday, and we'll be chatting about viruses and how viruses